प्रियंकुर पर प्रिया मैम नहीं दिख रही है.
She'll join in a minute, ma'am. Monica has called her. She'll be there.
Hi, hello. I have joined.
Okay,
Priyanka.
okay. Hi, ma'am.
Hi, everyone. Hello, sir. Yeah. Good evening.
Hi.
Are we good to go? Please let me know. It is already 5:10.
Are we good to go?
So this is a request to all of you. We are now on YouTube live. So good evening, all the respected faculty members and all the delegates. A warm welcome to all the delegates on YouTube and all other online platforms. So Public Awareness Committee Fogsi, Amogs, PEC and YTP Committee in association with Maharashtra, Rajasthan, Goa, Gujarat and Madhya Pradesh Society welcomes you all on 5th episode of Core Connect live webinar. So coordinator for today's live webinar are Dr. Monica Umbadant. She is in charge of PAC activities, and Dr. Shatabdi De, that is convener of PAC Foxy. Dr. Monica, she is an consultant OBS and Gynec at Mangalia Nursing Home and Atharva Fertility Center. She is chairperson for PAC committee Amogs for 2022 and 24. She is also website coordinator for Amogs. So without making any delay, I would like to hand over this session to Dr. Monica Umbadan. Ma'am, welcome.
Thank you, Bhumit, for the kind introduction. I would like to introduce our webinar series, the Public Awareness Committee webinar series. This is in association with all the West Zone societies of Maharashtra. We are a part of the webinar series, which is hosted every 15 days. This time it is in association with the West Zone, and our theme is cervical cancer prevention. I would request Dr. Priyanka to welcome all the esteemed faculty and delegates. Over to you, Priyanka.
Thank you so much, Monica. Good evening, everyone. It gives me immense pleasure to welcome all of you to this 5th episode of the Core Connect webinar. In association today, we have the Maharashtra, Rajasthan, Goa, Gujarat, and the Madhya Pradesh societies. And I would specifically like to welcome the Amogs Public Awareness Committee and the Amogs YTP Committee for taking active part in this webinar. I would first of all like to thank our president, dynamic president, Dr. Rishikesh Paisa, who has also joined us in this webinar, and he's joined us in all of our previous 4 webinars as well, and it gives us a lot of encouragement when he's there with us. I would like to also thank our Secretary General, Dr. Madhuri Patel ma'am, our Vice President in charge, Dr. Alka Pandey ma'am. Today we have the President of Amogs as well with us. Thank you, sir, for joining us, Dr. Rajendra Singh Pardesi, sir, and also the Secretary of Amogs, Dr. Sujata Dalvi ma'am. Dr. Kalyan Barmade, who is the past chairperson of PAC, has been an everlasting support, and he continues his support in all our activities. I would specifically like to welcome our guest of honors as well for today's program, Dr. Jaideep Tang sir, and also Dr. Madhuri Patel ma'am, and Dr. Rajendra Singh Pardesi sir also, who has also joined us today. Thank you so much for joining us. I would like to welcome our conveners as well, Dr. Ashwini, Dr. Vaidehi Marathe ma'am, and Dr. Monica Gupta ma'am for joining us in this program. Our speaker today, we are the topic for us, our webinar revolves around cancer, cervical cancer screening guidelines, cervical cancer and vaccination, and also modalities of conservative management of CS cervix. So it's going to be CS cervix that we're going to discuss primarily today. Our speaker, Dr. Priya Ganesh Kumar ma'am, who's an expert in the field, is there with us. And also we have our expert chairpersons, Dr. Lakshmi Shikande ma'am, and also Dr. MC Patel sir, who will give their expert comments. The panel will be moderated by Dr. Bharti Abhyankar ma'am, Dr. Vaidehi Marathe ma'am, and the second panel by Dr. Binal Shah and Dr. Monica Gupta. Our experts for the panels are Dr. Veena Acharya ma'am and Dr. Ajabrao Vasu sir. So welcome. Our expert panelists for the session today, Dr. Shashibala Bhosle ma'am, Dr. Brajbala Tiwari ma'am, Dr. Nidhi, Dr. Anjali, Dr. Monica, Dr. Rahul Vani, and Dr. Deepthi Vaidya. Welcome all of you. They'll be part of the first panel. And we have Dr. Preeti Sharma, Dr. Tavares, Dr. Surekha Taide, Dr. Jagriti, Dr. Ravindra, Dr. Neha Saraf and Dr. Alka Agarwal ma'am, who will be part of the second panel. So I would like to welcome all of you and also welcome the Core Connect team, that is Team Corona, for lending us their support in this program. So thank you so much once again for joining us. As Monica has said, just a reminder, we have our webinars on the 2nd and the 4th of every month, second and the 4th Thursday of every month, 5 p.m. onwards. So kindly make a point to join us, because we do it on a zonal basis, plus different topics every webinar. That makes it interesting for everyone. Thank you so much once again for joining us. Over to you, Monica.
Thank you, Priyankur, for the kind introduction of the webinar. I'd like to thank Dr. Ashwini Kare as the co-convener of our webinar today, because we have the Amogs Public Awareness Committee as well as the YTP committee who has been a part of this webinar. We always think that teamwork is an efficient way to handle things. So I would like to welcome Dr. Ashwini Kare to say a few words on behalf of the YTP committee.
Thank you so much, Monica. First of all, I'd like to thank PAC Committee Fogsi, the committee chairperson, Dr. Priyankur, for associating with the YTP Committee of Amogs. And I welcome all the dignitaries and all the delegates to this webinar on a very relevant topic, that is cancer cervix. Thank you so much, Rishikesh Pai sir, Pardeshi sir, Madhuri Patel madam, Sujata Darvi madam, Lakshmi Srikhande madam, and the Vice President Dr. Alka Pandey madam for joining us today in this webinar. Thank you so much. And I'm sure that the Public Awareness Committee of Amogs and YTP Amogs, along with PAC of Committee of Fogsi, will definitely be doing many such activities together in the near future. Thank you so much. Over to you, Monica.
Thank you, Pardeshi sir and Sujata ma'am, for allowing us to conduct this webinar under the Amogs banner. I would now request Priyankur to introduce our chief guest, Dr. Rishikesh Pai.
Thank you so much, Monica. Dr. Rishikesh Pai sir, who's the president of Fogsi, it's such a wonderful thing that he blesses us in all the programs, in all the webinars that we have done as of now, and I hope and I kindly request him to continue doing the same, because that gives us a lot of, as I have already said, gives us a lot of energy and enthusiasm to continue with this webinars. I'm also happy to mention that he in Delhi, when we had done the Gyan Jyoti conference, it was his first conference after taking over as president that he joined, or any committee conference that he joined after taking over as president. So sir, it means a lot to the Public Awareness Committee, to all of us. Your presence, of course, brings, as I said, a lot of enthusiasm and smile to all of us, sir. Thank you so much for joining us, sir. I request you to kindly give your remarks as the president of Fogsi, sir.
Thank you. Thank you. I'm really happy that you are having a joint program, PNCO, with the Public Awareness Committee of Fogsi, Amogs, and the YTP Committee of Amogs as well. So, there are a lot of senior people, Dr. Madhuri Patel, Dr. Alka, Dr. Jaideep Tank is there, Dr. Lakshmi Srikhande, our ICOG chair, and Dr. Pardeshi, our Amogs president and past vice president of Fogsi. And then we have got Vaidehi, Monica Brijwala, Lakshmi, Nidhi, Satabdi, Veena, Ajab Rao. I can see MC Patel also, Sujata Dalvi, Alka Pandey, my East Zone, Kalyan Baramade, then our Sureka Tade, then Priya Ganesh, and many others are there. Alka Agarwal, all of them are there. So I was just telling, just in another seminar, so I was just telling them that, talking about chairmen of Fogsi, when I was in Chennai, the chairman used to be nominated by the president. I was the first one to ask for an election, I remember. And that's how the election started in the Fogsi. And then again, after many years, I was one of the person who reduced the tenure of the, which is, I don't know whether it's a mistake or not, but I reduced the tenure of the chairperson from 5 years to 3 years. Of course, because there were too many people who wanted to become chairs, and but in that process of reduction of the chairs, we increased the number of people who started fighting for vice president post, and now it is reflected in the fight for the president as well. So because in India, a lot of good people are there, capable people are there, and ultimately it's a pyramid. So, I am in the process of evolving a new philosophy of cluster heading. So the this is a new philosophy which I am evolving, and I may present it to all of you in the next year when I create a new organization which will have about 90 people will lead the organization. So something similar to the Chinese Communist Party, where of course now that has also become pyramid by Xi running the organization, but something similar I have in mind, where I will have more people having the ownership at the top. So that's what I was evolving in my mind, and I'll implement it in practice. Let's see how I can succeed in that experiment with a new kind of structure. Anyway, coming to the activities of the Fogsi have been very rapid, very aggressive. We have already done 3 Yuva Fogsis, 1 ICOG conference, 1 Andaman conference, 1 big AICOG, which, though I can't take, but it's like my conference only. It was my president conference. In all this, Madhuri has been, our Secretary General has been very dynamic and very helpful, and all others as well are around us. And now we have a lot of other conferences coming up, a lot of programs, a lot of, cancer service. We had a fantastic program where 62 societies participated. We collected 4,200 very good data. Anu Chawla, Priyankur, Priya Ganesh, and Sureka Tadi, and many others, they did that program. I remember some, but there's so much of activity going on that it's sometimes you forget what's happening. But one of the important activities is that now the India night, where already, because I didn't want to create chaos. So first I told the leadership. The leadership, nearly 44 people have registered for their internal travel to UK. And first I asked all the chairs, the vice presidents, etc. Now we are going to open it up, and 40, 50 more people we can take. So that will be a fantastic, kind of program in London. And then we have the program coming in Paris. That is our FIGO conference. That will be in October. And the final program, which you must block your date, 24 to 26 November, is our conference in Mumbai, which will be a large conference. In the olden days, when I was younger, the Fogsi presidents used to do nothing. They used to have a presidential conference. That was in November, December. That's it. And they had their AICOG. And then Kamini Rao came in, and then the 4 Yuvas were added. And then someone came in and added the 5 vice president conferences. Then in the last 1-2 presidents had knocked out the vice president conference. They combined them into single. But I feel each of the vice president is an individual. So I said, no, they must do their own individual conference. That is very important. And so the structure, it's a dynamic structure. It keeps on changing. But remember that you all have to participate in these programs and be more active. So it's more fun. I don't want to take much of your time. I just wanted to tell you what is on the agenda, so in the future, so that you can participate. And one more thing I would like to tell you. See, it's very difficult as organizers. You can't remember everyone. So if you want to be in something, you must tell. You can't say, Dr. Pai ne mere ko bulaya hi nahi. I am not doing anything unintentionally. You must tell that, sir, mere ko aapne bulaya nahi. Then I will call you. Unless you are vocal, unless you are forthcoming and aggressive, you will remain in the backseat. So you have to be more expressive, and that's how you can come ahead. So anyway, thank you very much, and wish you the very best, Priyankur.
Thank you so much, sir, for joining us, and thank you for your blessings, sir. We all know that you are an inclusive person. You try to involve as many people as you can, sir. But of course, as you said, sir, if we do try to remind you in case if we are left behind, sir. Thank you so much, sir, for once again joining us, and thank you for joining us today.
Thanks.
Monica, over to you. Thank you so much, sir.
Thank you, sir, for the blessings, and thank you for joining us every time in our webinars. We feel connected. I would now request Ashwini ma'am to please introduce Jaideep, sir.
It's definitely a proud privilege to introduce Dr. Jaideep Tang, sir. He is the president-elect of Fogsi and a very dynamic person. And I always call him the go-to person. Any difficulty, anything in Fogsi you just have to make one call to Jaideep, sir. And he definitely answers it. And even if he misses the call, he'll definitely call you back. I'll officially introduce sir with his official CV. He's the secretary General of Fogsi in 2018 to 21. He was the project lead for Fogsi in the USAID projects, past president of Mumbai OBGY Society. He was also the past chair of Publication and Newsletter Committee, AOFOG, past chair Reproductive Endocrinology and Infertility Committee of AOFOG, and past chair of MTP Committee, Fogsi. Welcome, Jaideep, sir. May I have a few words of blessing from you?
Thank you, Ashwini, for that very warm and kind introduction. It is always a pleasure to be a part of any program of Fogsi, and it's even more of a pleasure when it's coordinated by Priyankur. I had taken to calling Priyankur the national coordinator because whatever is happening in the nation, he only seems to be coordinating. I really don't know when he gets the time to do anything else but Fogsi work. Well done, Priyankur. You are taking the Public Awareness Committee to greater heights, and I can tell you that we all have very great expectations from you for the future. So congratulations, well done, and keep it up. I must acknowledge also the presence of the President, Rishikesh, the Secretary General, Dr. Madhuri Patel, my very good friend, and of course, the Vice President, Dr. Alka Pandey, and the past chair of the Public Awareness Committee, Kalyan. I'm delighted that this program is being held with the Amogs. Amogs, of course, is like my mother organization, if I may say so. And I'm delighted to see Pardesi sir here, who is really one of our most wise persons. I always look to him for advice. So thank you, Pardesi sir, Dr. Dalvi, and of course, Monica. You have fantastic coordinators and conveners, Priyankur, Monica, Dr. De, Ashwini, Vaidehi, and Monica Gupta. And of course, I was just counting the number of faculty that are there, and I think you have together almost 21 or 22 faculty for something like a 3-hour program. So I think that speaks to everyone's enthusiasm to participate and be a part of Fogsi public awareness activities. I'm delighted that you've chosen cervical cancer, because I do think that this much stigmatized and relatively taboo topic is not spoken of as much as it should. And I'm delighted that you have Priya to speak on it with, again, a very dear friend, Dr. Lakshmi Srikhande, who's the chair of the ICOG, and Dr. MC Patel chairing that session. And then you have 2 very interesting panel discussions with very, very eminent panelists. Thank you again, Priyankur. Thank you, Monica, for coordinating, and thank you, Ashwini, for introducing me. And it's always, as I said, a pleasure to be here. Thank you.
Thank you, Jaideep sir, for being there, sir. As Ashwini said, it's always a go-to person for whatever we need, sir. And the callback is definitely something which I'm sure not only me, everyone will agree to. If in case you missed the call, that is also rarely. So thank you so much, sir, for joining us, and thanks for your blessings, sir.
Thank
you, sir. Thank you for joining us today. Now we move on with the program. I take privilege to introduce our Amogs President, Dr. Rajendra Singh Pardesi, sir, as a guest of honor.
It's okay. It's okay. Monica, it's okay. We can.
So Priyankur actually said Jaideep sir is the go-to person in Fogsi. Pardesi sir is the go-to person in Amogs. He, being at the helm of the association, he is still yet very humble, very approachable to all the chairpersons, and he is the ever-encouraging person that I have ever seen. Thank you so much, sir, for joining us. Can we have your blessings, sir?
Thank you, Dr. Monica, for kind words. Good evening, everybody. Respected Chief Guest, Dr. Rishikesh Pai, sir, Dr. Madhuri Patel, Dr. Jaideep Tang, Dr. Alka Pandey, Dr. Lakshmi Srikhande, and Dr. MC Patel, sir, Dr. Sujata Dalvi, and our chairpersons, ever active chairpersons, Dr. Priyankur Rai, Dr. Monica Ubardhan, Dr. Sureka Taide, Kalyan Baramde, and Dr. Priya Ganesh Kumar, and our Amogs state coordinator, Dr. Bharti Abbenkar. Bharti Abbenkar is very active in this field of preventive oncology. So first, I wish to congratulate Dr. Priyankur Rai and Dr. Monica Ubardhan and Dr. Ashwini Kale for organizing such a practical webinar on cervical cancer. I salute to all the faculty, chairperson, and panelists for participating in this webinar on cervical cancer prevention and management, which will reduce the morbidity and mortality. With the galaxy of faculties, chairpersons all over from Maharashtra, Rajasthan, Goa, Gujarat, MP societies, I think this will going to be a great program. Wishing every success to Dr. Priyankur, Dr. Monica, Dr. Ashwini, and wishing every success to this webinar. Thank you so much. Thank you.
Thank you, sir, for your kind words. We now move forward for the next session. Can I ask Dr. Shatabdi to please introduce Madhuri ma'am, our guest?
Yeah, and before Shatabdi, you do that, I would just like to once again thank Pardesi sir for joining us for this program. And of course, we know, sir, you have been like our pillar of support for many of us youngsters, especially in the field of OBGYN, sir. Thank you so much, sir, for joining us and for your blessings, sir. Shatabdi, can you please introduce Madhuri ma'am?
Yes, a very warm welcome to everyone for this session today on cervical cancer. It's my immense pleasure to introduce our very own dear Dr. Madhuri Patel ma'am. Madhuri Patel ma'am, as we all know, is the Secretary General for this Fogsi presidential year. She has also been the treasurer as well as the joint secretary in the past. She is an honorable clinical associate at Nauroji Wadia Hospital as well as at the police hospital, as well as the visiting consultant at Elizabeth and Masina hospitals in Mumbai. She has also been the chairperson on the study of female breast committee in the year 2010 to 2013. A very warm welcome to you, ma'am. We would like to hear a few words of encouragement from you, ma'am.
Shatabdi, can you hear me?
Yes, ma'am.
Yes, Madhuri.
Yeah. Thank you, Shatabdi, for your kind and generous word. Respected our Fogsi President, Dr. Rishikesh Pai, most dynamic and visionary. Then our President, Amogs, Dr. Rajendra Pardeshi. We are very good friends. And of course, our Dr. Jaideep Tang, with whom also I had a chance to work when he was a Secretary General, and now I'll be working with him as a Secretary General with him when he takes over as a President in 2024. And of course, we have our Secretary of Amogs, Dr. Sujata Dalvi. Then we have another Dr. Lakshmi, Dr. MC Patel, Dr. I cannot forget Priyankur, and whose committee activities there along with the Amogs committee, and Dr. Alka Pandey, who is the committee in charge, Vice President in charge of the committee. Then we have Dr. Priya Ganesh, who is doing lots of work in elimination of cervical cancer. Then today we have three Monica. I did not try to remember, their surname, but there are three Monikas, and of course Shatabdi, Ashwini, Vaidehi. Then we have Dr. Alka, Dr. Sureka, Shashibala, Rahul, Bharti Abhay. There are so many. In case I can't take name because I'm on my mobile, so I can't see everybody. So all dear friends, very good evening to all of you. At the outset, I would like to thank the organizer for giving me this opportunity. As Dr. Rishikesh, Dr. Rajendra, and Dr. Jaideep has always said, but I always, as a Secretary General, I always like to mention about the Fogsi, that the Fogsi is most vibrant, prestigious, and one of the largest OBGY professional organization in the world, with 266 member bodies and 39,500 plus members committed to women's health. Fogsi has 28 committees chairs, and you can see Priyanku and others. They are doing excellent work. As Dr. Jaideep has pointed out, that Priyanku is only the national coordinator, for Fogsi, and it is a fact that he is also doing not only public awareness only in one particular aspect, but anemia. Now he has done the anemia program. It is still going on, and he has literally tasted, I don't know how many so far, but it is going to be lots of data we are going to get, the hemoglobin level of our women in India. So that is very good. And Priyankur is not only active since he has taken his chairman post, but he has also was very active before that. So Priyanku, I congratulate you and wish you best luck. Then Fogsi has a mission that we protect and support the OBGY practitioner in India. Then Fogsi believes or encourages a dissemination of the knowledge, research, and education Foxy also has a mission. It serves to advocate the cause of sexual and the reproductive health of women and its right. And our primary mission is reduction in maternal mortality rate. Now, what has happened? There is a formula called 30, 60, 90. Now, the women maternal death is 30,000 annually in India, but 60,000 women annually are dying because of the cancer service, and 90,000 women are dying annually due to cancer breast. So, we realize it in Foxy, and we have also added our mission last year that our mission is preventive oncology and elimination of cervical cancer. So these are very, very important things. Of course, Dr. Priya will talk about 90, 70, 90 WHO, slogan, which, 90%, women should be, and 90% girls should be, adolescents should be given vaccine, HPV vaccine, 70% should be screened, and the 90% should get the treatment. So we had a meeting last year with a government official. We convinced them by the HPV vaccine is very, very important for the prevention of cervical cancer. And very soon, with the Foxy efforts and the government efforts, we are going to have indigenous HPV vaccine in our national program. So that is a very good achievement. And of course, we near future will definitely have cervical cancer elimination. So with this, I congratulate, the organizers for the most apt webinar, and I wish them best luck. And we have today eminent, as Jaideep has pointed out, we have 21 faculties. So they are going to give expertise on the subject, which will help us in day-to-day practice, and which will help our women. Our women will get benefit out of it. So I thank you once again for giving me the opportunity.
Thank you so much, Madhuri ma'am, for joining us, ma'am. It means a lot, and your remarks means a lot to us as well. We have seen in the last year how hard you have worked towards bringing the various issues and various like election-related issues, etc., that we had last year, and how you brought it all together so that it benefits general Foxians in toto. So thank you so much, ma'am, for being there today. And just to answer, ma'am, once the anemia project that we were doing is going great guns, ma'am. I just like to mention and thank all of you for your active participation in it. On the 20th of this month, we had crossed 1 lakh plus testing women for hemoglobin across the country. And I think by today, we are somewhere around 1.15 lakh in the total number of testing that we have done. So we hope to get good data that will bring getting the population who are more anemic and trying to test them and trying to also treat them so that it decreases the chance of maternal mortality as well. Thank you so much once again for the opportunity.
Priyanku, great work, but I would also like to add that, don't only analyze the patient, but also analyze that who are the anemic, more anemic in which area. So we can also concentrate on those areas.
Absolutely.
So that
we
also
want to do that, ma'am. The area-wise distribution and also the age group-wise distribution is something that we're looking at, ma'am.
Okay. Great.
Thank you so much, ma'am. Thank you.
Okay.
Monica, over to you.
Thank you so much, ma'am, for joining us and blessing us always. We now move forward to the next academic session. This is a lecture by none other than Dr. Priya Ganesh Kumar. Bhumit, can we have the chairperson series, please? Our first chairperson is none other than Dr. Lakshmi Srikhande, ma'am. She is currently the ICOG chairperson. She is a medical director at Srikhande Fertility Clinic at Nagpur, Maharashtra. She has also been the national corresponding secretary for the Association of Medical Women's India. She has been the founder and patron president of ISPA Vidarbha chapter. She is also the chairperson of INS Education Committee 21-23, a president, Association of Medical Women, Nagpur. She has also received the Nagpur Ratna Award with the hands of the Union Minister, Shri Nitin Gadkari. She has received the Bharat Excellence Award for Women's Health, and the list goes on. We welcome you, ma'am, for being the chairperson of this session. Sir is currently is president-elect of the Gujarat Obstetrics and Gynecological Societies. He is a consultant obstetrician and gynecologist as well as a medical counselor. He has been the vice president Fogsi in the year 2018. He has been the organizing secretary of AICOG 2017. He is also the chairperson of Ethics and Medical Legal Committee Fogsi in the year 11 to 2013. He's been the joint organizing secretary of the SOGOG of the year 1921, as well as the organizing chairperson of the MMCon 2018. We welcome both of you to chair the session.
Thank you. Thank you so much, Monica, for your kind words. Good evening, one and all. And I must say, Priyankur, you are doing great. Great work and keep doing it. So can I have the CV slide of Priya? I know Priya doesn't need any introduction with the amount of work she has already done for her committee and in the field of cervical cancer prevention. She's the best person to give this talk on cervical cancer screening guidelines. But just to introduce her formally, Dr. Priya, Priya ka formal introduction to dikhao. Otherwise, I can just go on speaking.
Bhumit, can you please show the slide?
Priya, you just show your first slide. That must be your CV slide. Yes, as I was saying, Priya, you are the apt person to speak. She is running various mentorship programs, the training programs, and you can see her list of awards which she has received, the books and publications to her credit. And the key position she has held in the past is she was ex-HOD, Preventive Oncology Department at CR Wadia TMC, ex-PCPNDT Chairperson, Thane District. And friends, I must say that she is a great organizer and a great working hand to Fogsi in this field of preventive oncology. So Priya, the floor is all yours.
At the outset, thank you very much, Dr. Lakshmi Madam. It's actually an honor to have you as you and Dr. MC sir chairing this session. And of course, thanks a lot, Priyankur and the organizers to invite me. So I'm going to share this. Yeah. All right. So thank you very much. And my topic given today is, now this March is a month of, cervical cancer, and hence this is the right time when this, this topic is being chosen. And I must congratulate Priyankur for the efforts which he's been putting into getting various topics around every month. So thank you very much. And I bring greetings from my Mumbai branch. So cancer is, as we always have been doing, today my topic is given to me is cervical cancer screening. And I'm going to get to you few different, screening guidelines and how to utilize these guidelines into our day-to-day practice. Otherwise, we always do rote learning, and we should be having this practical approach of how to utilize these guidelines. That's a basic purpose of today's my lecture topic, and to encourage people to utilize it. So cancers are very common. I mean, it's very easy to know a cancer. No, there's nothing big into it. We take a biopsy, we know about it, that this is a cancer. Finally, its management is definitely a challenge about it. But what is the ideal thing for we as a Foxians? Where do we shoulder the responsibility? We shoulder a major responsibility. The biggest responsibility I feel is shouldering to identify this, the submerged iceberg. And that is absolutely 10 to 15 times more than a cancer. So even if you can really, truly can identify them, and how do you identify them? They don't have much symptoms also, no? So that's the biggest challenge. And that's exactly where screening comes into the part. Knowing the fact that 1 out of 4 is dying out of cervical cancer globally. Now, we do not want this slide every now and then to be projected, because this doesn't make any sense. We had all gone so ahead in nanotechnologies, and everywhere an Indian is doing a fantastic job. But why should an Indian suffer with a cervical cancer globally, and that to the 1/5 part or the 25% is being shouldered by India, we know that we are a populous country, but still, I feel it's high time that we really put efforts into screening. I must congratulate Fogsi leadership for their very great efforts, tremendous efforts taken to get the vaccination drive into the government program. And that was really a remarkable step towards getting elimination call and the drive. Talking about, you can see over here, this is the Globacon 2020. And you can see cervical cancer is contributing to 18.3%. The incidences are 1,23,000 now. And when you talk about the deaths, you can see the deaths have increased to 77,348. If you actually see, ASR has reduced, but because of the population also, and now histopathology is also being done more seriously, and so now the deaths, the cause of deaths due to cervical cancer is like now being understood, and that's the reason in our this national cancer registries are now also doing, they have been doing the tremendously good job, but now a more focused job. And hence now you see that these rates are now highlighted. They are coming up into our understanding, into our radar. And we then try to understand how we can bring this down because of screening, the major thing. Now you can see breast cancer is 25.8 per 100,000 women, and cervical cancer incidences are 18 per 100,000 women. And if you want to see the death due to breast cancer, it is 13.3 per 100,000 women, and cervical cancer 11.4 per 100,000 women. If this is the, look at the difference, it is 7 in incidences per 100,000 women, and mortality is just 2. Why so? Because even today, cervical cancer, they come to us only in the later stages. And they do not give, the ladies are yet not that sensitized. Our own fraternity is not that sensitized towards the screening, and we should be taking it more seriously. This is our 2018 Globacon, and you see that time the death due to cervical cancer was 60,000. Now it has gone to 77,000. Now means that is again a 2020 Globacon. 2020 Globacon is somewhere I had seen, but I couldn't actually identify, get those figures for you all. There also it is showing that. Now you see, this is the latest 2022 cancer incidences estimates taken directly from National Cancer Registry Program. And you would see over here that they are saying that the cumulative risk for a cervical cancer is going to be 1 in 75. And the age incidences, the age group which they have shown is cervical cancer is second leading cause of the death. And look at this age group. This is the middle age. That this is 40 to 64. And that is why our even WHO is stating that at least if you do twice in a lifetime screening at 35 and 45, this is going to be picked up, So that is very, very important. And this is showing, this is from the ICD's 10th revision. And you can see the projectile, what they are showing. So this is again something of a concern in 2025. So we really do not want this to happen. When we have seen that in all the states, there has been shown a race. There has been a race over a period of time. So we have this WHO which calls, the call states that, there is a possibility of elimination. That is, what is an elimination drive? Less than 4 per 100,000 women. If we adhere to this 90-70-90, Madhuri madam was telling the same thing. 90 is coverage of HPV girls below the age of 15 years by 90% with vaccination, of those girls being covered with vaccination. 70% of women of the screening population. And here they are more stressing with a high performance test like HPV. And they are saying even at the age of 35 to 45, even if you do twice, if 70% of these are covered by screening, and the 90% of the screen positives, maybe for cancer or for pre-cancer being treated, definitely the strategy can come up as world free of cervical cancer. So we know this, and primary prevention, secondary, tertiary, and palliative. knowing the fact that why should one screen is we really want to identify the CINs and we want to curtail that. The management also is very important, not only the screening. And management definitely is not hysterectomy. My chair, another chair is MC Patel sir. He would be the right person to say as in MLCs. Nowadays, the MLCs have really raised in such a way, and even in, you see those medical legal, this thing, you would see many a time, gynacs are only the main target. And nowadays, this is again increasing. What is increasing is if you do a hysterectomy for a preventable disease like a CIN, these are also coming under radar. So dear friends, let us understand that we do have the proper conservative management and we better stick to our understanding of this and implement it in our clinical practice. Now there are CIN1, if you say. In our country, people are not very serious. They don't come back. Might be they get so scared, you say CIN1 and they go for hysterectomy. So we all have to become very vocal. We have to say that repeated screening is the key for it. Not one-time screening and then finding something and oh my God, and making a hue and cry and removing the uterus out. It cannot solve the problem, because even if you remove the uterus out for CINs, you're not escaping VAINs. You're not escaping vault in neoplasias or vaginal epithelial neoplasia. So you will have to understand the conservative part. We have to curtail in this green zone rather than going into the red zone. And going up from there, one thing which we wanted to always understand, is screening enough? So vaccination has to be a part of it. You cannot say that I will just do screening and I will not be talking about vaccination. Not my part, it's a pediatric part. No, not at all. This is one of the fantastic impact study which has shown that only if you do a vaccination, 44% is curtailed. Okay, but if you have a vaccination along with screening at least twice in a lifetime, look at this, it is showing 61% reduction. So this is the impact of cancer reduction. And here they are talking only of VIA, and when we are talking, we can always advise our patient for going into HPV and all that, so you can understand where the level impact can it be. So what is the importance of screening? Why should a lady screen? Because this has been done for people who are not having symptoms. Basically people are coming at us through symptoms. Definitely people are coming with us and we are then screening. That is a different ball game. That is a clinical diagnosis. But this is the importance of screening, is talking to a lady saying that if you're going for a why are you doing a HB1AC? Why are you doing a thyroid? Why are you screening yourself for a hypertension? Because you want to know what is the status of all that. Similarly, everyone should be in a, we are the counselors. Who else can it be? We are the counselors, and only we can do this. I really feel that. By informing, educating the families on the importance of proactive screening is very important. But whenever it comes for the screening thing, the first thing is we all start scratching our head thinking, "Are kya karna? Should you do a cytology or HPV or VIA?" So many of this cafeteria approach and so many of those jargons, so many things. Chodo na, uske badle karte nahi hai. So this is exactly our mindset. So adopt whatever you have. I'm not saying that one thing or other, but the best part is doing an HPV. Now, we see so many barriers for screening. We did not even tell it. We know it now because we know the barriers more than what we know anything now. Because we ask them to lie down on the couch, they don't lie down. They don't say, are not accepting the fact that cancer hame bhi ho sakta hai. This word cancer itself is so obnoxious, the word. That is why many of you all know, we in our oncology committee, we came up with the word SSNPP. Swasth Sundar Nari, prevent the preventable. We wanted to make it more positive. We cannot say cancer karega to koi nahi aa raha hai for lying down on the couch and all that. See, the prevalence of cervical cancer screening in our country is really minimal. This 7.1 is at South India, where the challenges were little less compared to you go to rural Maharashtra, you go to Gujarat, the screening would be just 1.1 or 3 or 2%. So, dear friends, it is definitely Screening is done for apparently symptomless, healthy women. Low resort setting has VIA, VILI. High resort setting, definitely HPV DNA stands a better chance. Core test nowadays is not taken up as screening. Let me be very honest with you. It is either you go with an HPV test or a VIA test. Cytology again, if you can keep it as a triage test, it would be the best thing to do. How many people come to us? Most of the people who come to us are all in this category. Look at the cervixes which are brought for you all. There are so many different stories. Each cervix is telling a different story. Each cervix is different. And understand, so these are the cases when these people come to walking to our center and to our place. Definitely we go ahead doing a colposcopy, we go ahead trying to understand their pap test and trying to understand their HPV status and all that thing, and then treating them. But that's not screening. That's absolutely a clinical diagnosis. They're coming for unhealthy cervixes. So now what we understand by screening, how should you counsel a patient? That's very, very important, counseling. So you have this as a normal cervix, if I can say this. And I always say this way, I adopt this methodology of counseling and I say, this is cancer. So then they say, yes, it is cancer. Then I ask them, do you think what is this? They say that there is something inside hidden. I said, yes, this is a hidden part, which you have to actually come out. They don't have symptoms. And we understand by doing tests like HPV test, we understand that that out of 50% in the sexually active population in the country would have HPV sometime or the other in the lifetime. They are low risk and high risk, and mostly when we understand 1618, non-1618, there is a fantastic protocol of how to go about with it. Do not get baffled. What I have seen after training more than 1,000 gynecologists in this field of colposcopy, what I have understood basically is whenever there is an HPV 16, 18 or something coming positive, people truly get little restless, even we as gynecologists, and we start thinking, Are, kya karna hai? Because 16, 18 will lead to cancer. It is not that everything leads to a cancer. It's not like this so easy. So there are those protocols, and knowing that fact that now look at that. Whenever we are doing, pap test, many a times a normal cytology can also have an HPV 16, 18, 5%. Low grade lesion will have an HPV 16, 18, 28.2%. High grade definitely is high, and cervical cancer is much more high. So how do you then understand us? Because many of our gynecologists still in the country are with pap test. They have shifted to LBC is another thing apart, but knowing this, having a pap, negative NILM, still there can be a chance of having an HPV and all that, and hence you have to be a little bit more cautious when you take a pap because it is a less sensitive test. And so this understanding should be there. So the span of diseases, HPV infection, having certain changes, which you pick up on a pap test, which you pick up on a VIA test or a colposcopy, do a biopsy, and you understand what is the whole story behind the CINs and all that. And nowadays it is, whenever we are seeing this, we say low grade and a high grade lesion. So low grade lesion is CIN 1 and high grade. So we go with this 2-tier system. SIN 2, SIN 3 goes in high grade. Now there is a paradigm shift. You can see over here, VIA is there, PAP is there. Then you also have HPV. There are different types of HPV tests which has also come up. Now, dear friends, whenever we are talking about cytology, let us adhere to the Bethesda system. That's extremely important now. And PAP has a long story. We know this history of PAP test since long time. We have been doing it. Conventional PAP has always been there, even now in the medical colleges. So we should know how to make a slide, how to fix a slide, how to, and then what are the advantage of a liquid-based cytology? To make a slide is actually very important. People working in the medical colleges would, agree with me that most of the time, the samples are remaining into the spatula, we are throwing it away, 80% is discarded. Now that's not there in liquid-based cytology because you're going to put the whole thing on that solution of ethanol alcohol or methanol, whichever the solution that they give. And doing a liquid-based cytology is any which ways, it removes the inflammatory smear. Now the understanding of a liquid-based cytology is it increases the sensitivity of identifying low-grade lesion to more, high-grade lesions will any which ways be seen in the PAP test as well as in the LBC test. The chance of increasing to see the low-grade lesions becomes much more easier. And that is where your test of LBC truly works, less of an inflammatory smear. And that's what I just said. The sensitivity increases better by 12%. So, but the inflammatory part is always there, no? So then we have these challenges of PAP tests that, one of the studies said that 33% of PAP, which was showed NILM, had cancer, full-blown cancer. Why so? Might be that your spatula didn't go with the high grade, it wouldn't have touched that, it wouldn't have scraped that out. Or it would have left behind in the spatula itself. It was not transferred back. So many reasons, or subjective. It's a very subjective test. Visual inspection with acetic acid or with Lugols. Nowadays, VIAM is also being considered by WHO. That is enhanced with magnification, or even AI augmented is accepted. We know VIA that we prepare it fresh, and it has to be a 5% with 0.5 ml of glacial acetic acid, 9.5 ml of distilled water. So that makes 10 ml. Otherwise, 1 and 20 ml. Now, what exactly does it? It coagulates the intracellular protein, obscuring the passage of light. You apply it for 1 minute, and then you observe for 1 complete minute. When you observe, you listen, you understand the intensity, you understand the speed of occurrence, borders and demarcations, location of the lesion, and color uniformity or aceto white. Now, I will just quickly take through this is, see, it was happening in our country, in our curriculum is, VIA is not taught the way it has to be, because VIA really requires QC, QA, dear friends. It's not simple. Believe me, dear friends, it's not that simple. It's very simple to put it. But when you actually start doing it, and that's the challenge. And how do we understand that? By understanding the criteria of aceto whiteness. The criteria is with speed, and if it is a thin, shiny, translucent, appearing, disappearing fast, merging with the rest of the tissues, that is metaplasia, as VIA negative. So these are VIA negatives which I brought for you. These are VIA positives which are there. VIA positives, high-grade lesions cannot be missed out. I might say even a blind person cannot miss it out. A high-grade lesion. But where is the challenge? The challenge is to identify the low-grade lesions, which appears a little late, at that 1 minute of observation is the key point. Magical 1 minute. Do not waste that magical 1 minute. What happens is patient winces. We don't counsel the patient well. Speculum has flown away. That 1 minute is gone. Then you put a speculum, your low-grade lesion is gone away. You have not identified. That is exactly where the challenges lie when you do a VIA. So overt lesions definitely cannot be missed out. Now, you also have augmented, to come out of all these, you do have AI-based, nowadays mobile ODTs are quite there. They have this AI-based. So the sensitivity of understanding improves. Now, see, this is a normal colposcopy. And a normal shown on a mobile ODT. AI helps a lot also. Now, again, this was a little bit of a challenge, and AI showed at abnormal. Then the challenges of VI is there. There has to be a QC, QA in place. Then comes your HPV. Now, HPV NAT test, having a molecular test, is the highest precision test, highest sensitivity test. And you can vouch on their high negative predictive value. And understanding that fact that HPV is a root cause for cervical cancer. Understanding an HPV gives you a risk stratification of which cases to, screen further and take them into your radar and try to identify true positives and, remove out the false positives and keep yours with only true, with a high PPV values test. So then that is the triage. So you have a high NPV value with an HPV, then you triage it with something which is really very good test, specific test like VIA, PAP test. So these then, in an HPV, what happens? You have true positives as well as false positives. Okay, so you don't want to create an alarm. You don't want to create one tension. So what you do, you triage these tests, you triage it with VIA, or you triage to understand a lesion. that's how you take it up. So a good sensitive test, added to that a good specific test like VIA, PAT test, mRNA test. These makes the subject very, very comfortable. And definitely, we can all vouch for it now after the Indian study that a single round of HPV test itself will, avert so many diseases. And look at the Tamil Nadu study, which has shown that so many deaths have been averted if you can take at least one single time of HPV screening. And this is what the WHO is also stating. You have molecular, cytology, VIA test. And now coming to WHO guidelines. Now, WHO came up with 7 algorithms of screen and treat approach, screen triage and treat approach. Now, in screen and treat approach, what they're saying, you can either do a VIA, okay, with a low resource setting, or an HPV self-collected or clinically collected, and then follow with treatment. Screen triage and treat, they're saying if you're doing a cytology, you triage it with a colposcopy and treat if you're taking an HPV DNA as a primary screening. You triage it with 16-18 and then finally take it up from there. Like if it is 16-18 positive, you treat it. If it is not, then you do a VIA to identify, whether there's a lesion or not. Then there is another triaging method. As I told you, HPV DNA has come positive. Triage it with VIA to understand whether there is a lesion or not. Or triage it with colposcopy to understand whether there is a lesion or not. Or triage it with cytology. Because see, the specificity of VIA is similar to a cytology. So you can't deny the fact. So, having as this thing. So now I've brought to you, how will we understand only when we really, truly take this on our pen, take up algorithm wise. Now I have brought for you 7 examples of how to take it practically, these screening guidelines. So suppose if this is a VIA test, okay, if it is positive, how will you? So I've brought one case for you. This is a case of 35-year-old. She is VIA positive. Now how I'll treat her? Now the eligibility of treatment, the treatment eligibility, you should understand what type of treatment should I give. Now here we can put a thermal ablation. But we can't put a cryo, because if I put a cryo ball, it is going to go out of this. This thing is going to go out of my cryo ball. If you have a thermal, it's fantastic. You can do it. Okay. Now here I adopted, because my thermal machine was not not working. There was some fault with it. I straight away took up a LETS, you can do that also, not a problem. And then you also can have, you also have the biopsy with that. Then we follow it up at 6 months and at 1 year. So in this way, we see we are treating well. The second algorithm, HPV DNA, if it is positive and you are triaging it with, this is a screen and treat, so I've not triaged yet. So HPV DNA, if it is positive, how do you take up these cases? And I brought one case for you. Now, this is a menorrhagia case of 36-year-old. She goes to the doc for only menorrhagia fibroid. The doc does a co-test for her. And in the test, she has found 16 positive. And there was some problem. They couldn't take a biopsy. They sent the patient to me. That's the story. I have taken this as 16 positive. Let me do a treatment directly. Okay, that is how I took this up for a screen and treat protocol. I've done a LETS for her. And what have I found? It is an HSIL. In some places, there are microinvasions. And also, you would see over here, they went for a second opinion with Borges, and then they said that this thing is negative. You have to always see the margin status. That's very, very important. There was no microinvasion as per the second opinion, but it was going it was going inside, it was this underlying this endocervical glands. So it's not a cancer, it's but a SYN3. And what we have done is absolutely right for her. So see, HPV positive, straight away going for treatment. And moreover, if it is 16-18 positive, they have the propensity of developing 70 to 80% into cancer. Now see, relook colposcopy, absolutely normal. Just took up a biopsy to confirm. And because we wanted a proof, and that's a regenerative epithelium, and as a test of cure, HPV negative. So that's, so now how will we follow her up? Now, follow-up is very, very important. We have to call her up every, first of all, 12 months, 24 months, 36 months. 3 years is negative. Then you can put her up into your 5 years till 20 years. That's the important story. And now see another screen triage and treat. Cytology, as normally we all are doing cytology. Now, whenever I got a case of PAP as sketch. I did just a HPV that was also positive. And I've done, so this is the as sketch. how will you take up these cases? If it is more than ascus, please do a colposcopy. If it is ascus, more than ascus, take her up for colposcopy. I'll go back to this, is very important. If it is ascus, you immediately triage with an HPV test. If that is positive, go for colposcopy. Many times we are getting ascus. So now this is WHO strategy, which is saying that if it is more than ascus, definitely go ahead doing a colposcopy and treat. This is as sketch. This is a case. I have done a treatment there and then, and I've got SYN3. What you have to see? Margins status, and that's showing negative. And this is how we can take up cases. So when we know guidelines, it is easy for us to manage a case rather than getting tensed and troubled. Ki kya karna hai, how to follow, oh God, what to do, whom to call. No, follow the guidelines correctly. It will take you to the right step. Like this, see now this algorithm, HPV DNA positive, you have 16-18, go for treatment. If it is other HR HPV positive, do a VIA triage. If there is a lesion, then you treat. Same as here, I brought one case for you. 30-year-old, she's just come for I was ex-HOD in one of the largest screening programs of the country. So there, this lady is just walking, she's symptomless, and she is having 571 RLU. We have triaged it with genotyping. She's 16 positive. Look at the case now. And also it's a high resource setting. We had mRNA also. So 16 positive. This is the case. And we went ahead doing the treatment. We have done a LETS for her because this is going endocervix. And we have found she has SYN2, somewhere SYN1. We call her up after 6 months. And that's showing normal. And we have done a test of cure. That's in 1 year with HPV. It's negative. She is under follow-up now. Follow-up has to be every 5 years now for 20 years. That's the story. Now I come to the second last triage. Now what is this triage? If you have an HPV DNA, you will say, I don't have colposcope. I do not have, what you can do simple, no? You've done an HPV DNA, do a VIA and treat there. That's again a very simple thing. Look at this case now. 37-year-old, she's having a postcoital bleeding. She's going to various doctors. Then she was sent to me. What I did simple was I took a HPV. That is our protocol. We have been following this protocol in all the 35 centers in our chain of preventive oncology centers pan India. HPV coming positive. What we did, HPV is 18 positive. There and then VIA has been done. What is you are seeing? You are seeing this now. Here will I treat her? I will take a biopsy because this is definitely showing me as a cancer. There is a suspicion of cancer. Look at that. So do not be in a hurry to treat now. You take a biopsy. Wait. Biopsy showed adenocarcinoma in situ. Infiltrating carcinoma, adenosquamous carcinoma. So in this way, your guidelines really guides you. Another is you have a colposcope. Now you will say, I have a colposcope, Priya. So yes, do an HPV test. Triage it is a colposcope. Many of us are doing this. 40-year-old, she comes with a reddish white discharge. Her HPV is 18 positive. Now we've done a colposcopy. We have done a sweet scoring. We found it to be 6. And we found it that this is going endocervix. Hence, even if the biopsy was taken because it's first in the colposcopy thing, we took a biopsy, but we went ahead treating. Biopsy showed SYN1, but we still took up the understanding that since it is going endocervix, the modality of treatment would be LETS. So we went ahead doing a LETS for her. My sweeting came to 6-7. After performing the LETS, the histopath came SYN2. So here it's showing concordance with my sweet scoring. Very, very important. And another very important thing is you should know when you are following these screening guidelines, the treatment modality is equally very, very important to come out of the, the whole thing. I mean, to close the loop. And then you follow her up. After 1 year, we followed her up and her HPV 18 had come negative. Last algorithm, HPV DNA you're doing. Okay, that's come as, say, positive. You are triaging her with a cytology. Now, you can do a reflex cytology over here. Rather than calling her up again, you ask the patient, the laboratory, that that is the advantage of doing an LBC, HPV and all that, LBC container. So you can tell them, you reflex the same test with the cytology. Cytology coming, ascus or more, you will treat. So look at this case. 32-year-old, repeated post-coital bleeding. HPV test is 16 positive. Look at this. 16 is the positive HPV, and she's been triaged. I think she was called again. It was not reflexed. This is from one center in Haryana, this case. And her cytology has come to be ASK-H. Now, we have to go for a colposcopy. So now the colposcopy has been done. And in this colposcopy, you would see the positive sweet score to 9 to 10 sweet scoring high-grade lesion. Now, what you should do whenever you have a very high-grade lesion like this, there is a suspicion of cancer. Look at this, a dense acetowhite, and you've got abnormal blood vessels and bleeding on touch. Please do not be in a hurry to treat there and then. Take a biopsy, wait for the results, and the biopsy over here had come up with adenocarcinomas and squamous cell carcinoma somewhere. You can see over here focus of squamous cell carcinoma, well differentiated in the cervix. So that's the end of the WHO 7 guidelines. So prerequisite for applying a screening. It should be affordable. It should be reproducible. It should be quantifiable. It should be less cumbersome. Less observer variability, expertise, availability should be there. Longer recall period and good sensitivity with a low false positive, good specificity with a low false, false negatives, and here with low false positives. So I leave you, dear friends, with a wonderful statement that do not go where the path may lead, go where there is no path. You create your own path, and you see, you leave a trial behind. That's extremely important. I brought most of all my things are from my own atlas and my books. And we have been offering a lot of colposcopy courses. Many of you all have also taken part in that. It's very important that you learn. And now with Dr. Lakshmi Shikhande, madam, I would like to tell you the course which we did, ICOG course. I am still getting feedback that, madam, that course has really helped us to understand the subject very well. So such courses are very, very important to upgrade the knowledge. And these courses are all there. So thank you very much. So I leave you with fantastic, and I love to end with this, that valuables we carry will impress others, but the values we hold will inspire others. So thank you very much for patient hearing.
MC Patel, sir. Sir, you are here.
Hello.
Yes, sir.
Yes. So excellent deliberation, Priya, as usual. She has very specifically mentioned that vaccination and early detection reduces almost 60%, 61%. And it is very true, because as far as this part is concerned, prevention, early detection, and meticulous management, whichever stage we receive any patient, it should be meticulous management. And as far as screening part is concerned, she has very nicely covered the subject. So congratulations for that, Priya. And I have seen you working since long. In era of COVID, you had so many webinars for this. And after this, physical meetings, training programs. So you are doing such a wonderful work as far as this early detection of cancer, cervical cancer particularly, is concerned. And you touched that part of medical legal also. So it is equally important, because there are few allegations related to this type of cases. One, if it is not diagnosed in time, it was failed diagnosis, wrong diagnosis, or not in time diagnosis. So these are one area. One more area, was it preventable? Many a time question asked in court of law. If it was preventable, then what did you do to prevent it that? And very recently, we have one case in state of MP only. I am counseling our Foxian friend. 57 years patient having bleeding off and on, heavy bleeding since 2 to 3 years. She was treated by some other gynecologists, and she had been to this particular gynecologist. She had a sonography. It was bulky uterus. She went for hysteroscopic guided biopsy, endometrial biopsy and cervical biopsy. But luckily, it was not malignancy, no dysplasia, nothing. But when patient was fed up with this problem since 2 to 3 years, ultimately hysterectomy with salpingo-oophorectomy was decided. But for any reason, she advised that let us have an opinion from oncosurgeon also. And patient was admitted for hysterectomy, but next day morning when hysterectomy was planned, patient absconded from the hospital, and she had been to Bhopal and operated laparoscopically as far as hysterectomy is concerned. And now notice is served to our Foxian friends from Jabalpur that why you advise opinion from oncosurgeon. And it was mental trauma to us. And she has claimed 20 lakhs rupees merely for this ground. Of course, this is notice only. We are preparing reply to the notice. We will win the case, nothing to worry. But this type of problem, as far as cancer part, malignancy part is concerned, we are facing in our medical problem also. So we should be careful. But whatever you do, as far as vaccination is concerned or screening is concerned for early detection, it shows your consent to treat utmost care of your patient, and it goes always in your favor in court of law whenever you are facing any of your situation in medical legal problem. Because whatever you do to any patient, you should be in a position to justify it in court of law. So evidence-based, and you nicely mentioned everything about PEPs, the HPV and VIA, and interpretation of all this finding and follow-up also, monthly, 3 monthly, 6 monthly, and yearly, and then after 3 years. So whatever we do, if it protocol-based, evidence-based, and if we can prove in court of law, then we always in treating this type of patient. So thank you, Priya, covering the subject so nicely. And thank you, organizers, for inviting me to chair very important session. And I have seen Priya working since long. She is very hard-working lady, and she has taken mission to eradicate cervical cancer from India. Thank you. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you so much, sir. Thank you, Sikhande ma'am, and thank you, MC Patel, sir, for sharing a very
I think Dr. Monica is having some network issues. Thank you, sir. Thank you for your valuable opinion on that. Yes, we will move on to the panel discussion, our first panel discussion. Our first panel is on cervical cancer screening and vaccination. Over to you, Monica, for introducing the moderators and the expert, please.
Hello. Am I audible now?
Yes, yes, you are audible, Monica.
Thank you, Priya ma'am, for the elaborative talk. I'm sure you've made the job of our panelists very easy for the next panel, which is also on cervical screening methods and vaccination. Our moderators for today's session is Dr. Bharti Abhyankar madam and Dr. Vaidehi ma'am. Our expert for this panel is none other than Dr. Veena Acharya ma'am. Hello. So can we have Dr. Bharti Abhyankar madam's slide? Dr. Bharti Abhyankar madam has special interest in laparoscopy. She in adults and gynecology. She has worked as a chairperson on the preventive oncology in Amogs twice. She has also worked as a zonal coordinator Amogs. She is the first person to start menopause clinic in Kolhapur. She has been awarded fellowship.
Sorry, Monica, I think the introduction should be very short because we are already having delay in starting the session. So make it very short.
Sure. Ma'am also runs fellowship courses in preventive oncology. We welcome our next moderator, Dr. Vaidehi ma'am. Bhumit, can we have the next slide, please? Ma'am, first of all, let us wish a very happy birthday to you. Ma'am is a consultant gynecologist at practicing in Nagpur.
Monica, that's fine. We can move ahead.
Can we have the slides of the panelists, please, Bhumit? Shatabdi, can you just see? I think my voice is cracking. I can't.
Yes, Monica. We are able to hear Monica. Continue.
Yeah. Our expert panelist, Dr. Veena Acharya, ma'am. She holds a fellowship in IC and counseling in HIV and AIDS. She is also the ex-professor and the unit head of the department of Medical College, NGM College, Jaipur. She is a senior consultant and preventive oncologist at the Rajasthan Hospital, Jaipur. She has been the chairperson of ICMSCH, that is the Indian College of Maternal and Child Health, Narchi. She is the president of Rajasthan branch of Narchi. We welcome you, ma'am. Can I now introduce the panelists? Bhumit, the next slide, please. Next slide.
Monica, Dr. Abhankar ma'am will give one-line introduction and welcome the panelists so that we can.
I also need slides to introduce it.
Bhumit, can you please show the slides, please? The next slide, please, with Dr. Shashibala ma'am's TV. Bharti ma'am?
Okay, I'm supposed to. Okay, so good evening, friends. We have heard a lot about this screening and treatment. Everything Dr. Priya has told us very nicely. She has covered a huge and vast topic in a very short time. So I think you must be confused about what exactly the screening is. So here is our panel to guide you regarding the different modalities of the screening. Our Fogsi has given a very nice GCPR, that is good clinical practice recommendations. You can go on the Fogsi website and have the look about it. But our panel is going to clear all your doubts about it. So I welcome my panelists. Before that, my co-moderator, a lady with brain and beauty, Vaidehi, nothing more to say about her. And our expert, Dr. Veena Acharya, madam, a very senior person, a very respectable person in colposcopy field. She is the expert for us. And now I will come to the panelist, Dr. Shashi Bhosle. And she is a MSFICOG and president of Gwalior OBGY Society. Next slide, please. Dr. Brajbala Tiwari, she is mainly a consultant gynecologist and infertility specialist. And she's also having the credential menopause practitioner examination, the CIMP, I suppose. She has cleared a CIMP examination also. Next panelist is the director and IVF consultant. I can't see her name. She's Monica. I can't see her name.
Ma'am, I'm Dr. Nidhi Vasani.
Oh, sorry for that.
That's fine.
Thank you. Thank you. Next panelist is Dr. Nidhi Vasani. She is mainly, I think you are mainly an infertility person, but still keeping a lot of interest in colposcopy and preventive modalities, right?
Yes, ma'am.
Next panelist is Dr. Anjali Jamma. She is now president of Solapur OBGY Society, very dynamic person, very active, conducting many activities in Solapur Society, which is already a very active society. The next panelist is Dr. Dipti Vaidya. She is a fellow in IVF endoscopy. She's from Baroda, and she was the ex-lecturer MGM College, Aurangabad. Faculty MRCOG in local and state level conferences. Welcome. Next panelist is Dr. Rahul Vani. I got some wrong name before that, but this is the correct name, I suppose. He's a honorable consultant, Mathadi Hospital Trust, and President Navi Mumbai Obstetric Gynec Society. Next panelist, Monica Kulloli, again from President of Sangli, a very enthusiastic person, a very busy person, but still keeping a lot of interest in colposcopy and cervical cancer prevention. So next panelist, I think almost all have been done. So I welcome all the panelists, and we will discuss various modalities of screening, various modalities of vaccination. I think you must be practicing the screening for cervical cancer. So what exactly is screening, that we're going to tell to our audience. Before that, I would just like to say one paper presented from Dr. Shankar Narayan IR. He had told about the impact of visual inspection. We have heard from Dr. Priya that there are so many modalities, and nowadays HPV is a primary screening modality, but impact of visual screening approach is very, very important, especially in low resource settings where HPV testing is not possible. So one round of VIA will detect more than 50% of CIN2, more than 75% CIN3, and almost 100% cervical cancer cases. So VIA has a role still today. So we will be seeing the first slide. Let me share my screen. Please allow to share my screen. So we will start later, Dr. Vaidehi.
Yeah, ma'am. Full screen wide side. Make it full screen, please.
Yeah. Okay.
Yeah. Can we move forward on the PPT? Yeah.
So
we all have been introduced to our esteemed panelists today. And a very important part of cervical cancer prevention is screening. So my first question is to Dr. Sashibala, ma'am. So what is basically screening, and what are the criteria of an ideal screening method? Because this is the most important part of prevention. Over to you, Sashibala, ma'am.
Yeah. Hello, everyone. Good evening, everyone. Thanks for making me a panelist here. Now, coming to the point, what is screening? See, screening is the utmost importance, and it is the first thing. It is the first step before prevention, and it can be called secondary prevention, so that we catch it young. We catch the systemic application can be done for preclinical lesions or asymptomatic persons. They come to us, they are not knowing. So screening helps them, and we can catch them. So it should be mostly selective. So selective, it can be for a high risk group where we see multiparas and all high sexual practices they are following. Or in the masses, it can be done for all the populations. Like in government hospitals, I'm serving in a government hospital where we do for every female who's coming there, we make it a point. Nowadays, so many people are not doing PVs as well as PS. So we make it a point to catch it. We have to do a PV. We have to do a post-speculum examination. And then we have got paramedics. We have got a system there. And we let them go in for a VIA, so visual inspection. Now, as you said, what should be the criteria for the ideal screening test? As Madam Priya just told us, it should be affordable. It should be cheap. So the more and more people can come forward for that. It should be simple. It should not be such a complicated procedure that people shy away from that. And of course, it should be high sensitivity with low High sensitivity means it should have low false negatives, and it should have a good specificity with low false positives. So as and acceptable to the population, I tell you, it is the first barrier is that we have to convey in simple language how it is important for them. They feel we do it for our advantage, that will get promoted or something like that. We tell them it is for them and it should be acceptable and it is very easy and not harmful. And it should be accurate and can be performed easily by paramedics, and it should be repeatable. So even if you have to do it once, we can do it again. So I think that is all for the criteria for an ideal screening. Is it okay, Vaidhi, or anything else?
Screening is that it is a systemic application to asymptomatic woman. It is not that the patient is coming for a white discharge or abdominal pain and you are doing her pap test. No, it is not like that. For any complaint, the patient is coming to you, you have to do her screening, whatever method you follow. And there is one more modality called as an opportunistic screening. That should be followed by each and every gynecologist. Whenever a patient comes to you for insertion of copper T, suppose, then before doing insertion of copper T, you do her screening, as well as when you are doing tubal ligations. Nowadays, this is a season for tubal ligations, April, May. So that time, before doing the procedure, you just screen her. It will take hardly 5 minutes. So that was well answered, madam.
Yes.
So next, I would like to ask Dr. Tijbala Tiwari, what are the different methods of cervical cancer screening? Can you please enumerate?
Yeah, good evening, ma'am. So cervical cancer can be screened easily. No fancy things are required. Simply like told by Dr. Shashibala madam, that PSPV is the must. Then traditional cytological pap smear, which we are doing, it not only gives us the about cells, atypical cells or dysplastic cells, but about the infection as well, other type of infection. HPV testing is the best one because it is the virus, human papilloma virus only, which causes cervical cancer. So HPV is very good, but in our country, like where rural population is more and we are not having so many doctors, their visual method is the easily available and can be taught to our paramedics, nursing staffs, and other staff as well. So these are the screening methods.
Okay, so can you just elaborate about the cytological methods? What are they?
Like in cytological, we were doing since long time PAPS test. That is and that should be done in the proper way. Even it has having a low sensitivity, but it is highly specific test. So conventional pap smear is okay if we are not having, but a pathologist must be trained and we should get the proper smear. We have to rotate and that should be done properly. Then the LBC, because it gives better result as compared to the lacunae of the paps is overcome in that. Then HPV testing by HPV DNA PCR hybrid capture and other newer method like this mRNA and E6, E7 protein, which is not available so frequently, but routinely we are doing PAPS and HPV. And via VIM, these are really good tests for to get, but these are giving information about CIN2 and advanced cases. So for early catch-up, the HPV is better.
Yes. So other methods like colposcopy, etc. These are the names to be mentioned. What we follow is a colposcopy that is routinely done. And in physical methods, we have TrueScan, fluorescence spectroscopy, and autofluorescence colpoprobes. So you have elaborated about these different methods of these, the cytology. Here usually we have advantage of LBC over conventional PAP, because as Dr. Priya has shown us the cases how we miss the diagnosis in a conventional PAP. This is not the case with liquid based. Only thing is cost. The liquid based is more costly than the conventional PAP, and that is the thing, but the results are very good. Once you are used to it, there is nothing like a liquid based cytology. So my next question is Dr. Nidhi. Dr. Nidhi, please tell us about the PAP test types, advantages. Just now I have elaborated advantages and disadvantages and what you follow in your practice.
Madam, as it has already been mentioned that there are two basic types. One is the conventional PAP in which we do the cytology and the slide is fixed and sent to the laboratory. And then we have the liquid-based PAP test. Nowadays, we do have the auto PAP also available. But these are the two most widely followed types of PAP tests. And in routine practice, we use LBC, the liquid-based test. Now, the advantages are that PAP test has stood the test of time. It has been there for years and it is still holding true. So it is widely acceptable across the globe and it meets all the requirements required for mass screening, because when we are talking about CA cervix, we have to look at mass screening protocols. Although it has a low sensitivity, the good part is it has a good specificity which is necessary for a screening test.
Yes.
So these are the advantages mainly. And LBC, as we know, we can combine the HPV. So that is another added advantage when we do an LBC. But disadvantages, I would say that there are very few, although we have mentioned a list, but it has more advantages rather than disadvantages. If we talk about the disadvantages, it requires a good setup, a good infrastructure. You have to train your staff. If you are doing it yourself, there's no problem. But if you are doing it with paramedics, they have to be properly trained. Then you need a good cytopathologist to report your slides or your LBCs, because that can make a whole lot of difference. And these tests are not once in a life. They have to be repeated at regular intervals to make sure that our screening program is adequate. And Dr. Priya gave us a very useful tip today. At least 2 screenings in a lifetime, around 35 years of age and at 45 years of age, also go a long way. So this has to be repeated. This is not once in a lifetime test, but still at the end of it, it is the test which is time tested and will remain so till we find some better alternative.
Yeah, but it asks your cytologist whether they are giving the reports in a Bethesda format.
Exactly.
So
it is equally important to interpret the results and have a replica. So if the test is positive and the patient goes to another place, there has to be a replication of the test.
Yeah.
Yes, perfectly said. So a good PAP done and the PAP test has gone to a good cytologist and you get a good, well-interpreted PAP smear report. My question to Dr. Anjali is, once you get it, how do you interpret such PAP test results? Because we have our patients whom we have to answer to. So how do you interpret PAP smear results?
Good evening, madam. Proper interpretation of PAP smear is very much needed to decide further management. In these, we may have atypical squamous cells in which undetermined significance is noted, in which we cannot rule out LCL. And some shows atypical squamous cells. In these atypical squamous cells H. In this, we cannot rule out HCL. And in some cases, like next stage is LCL. This is low-grade squamous intraepithelial lesion. And these 3 lesions we need to follow up regularly. And next we can see the high-grade squamous intraepithelial lesion, which is a precancerous lesion. And next is a squamous cell carcinoma. First 3 stages we need to regular follow and advise proper treatment for that.
Yeah. Bharti ma'am, can we take Dr. Veena ma'am's expert opinion?
Yeah. So one thing is missing, that is normal. What is normal PAP? All you have shown is an abnormal things. So what is normal? This is called as an NILM. That is the usual report that is negative for intraepithelial lesion or malignancy. Yeah. So that is NILM is a normal thing. Yeah. All these are the abnormal thing. Yes, Dr. Veena madam, please. We would like to have
the most important thing that we previously classified the PAP smear by the WHO or Richard system, but recently Dr. Priya has focused. This is the uniform system of classification, Bethesda system, and one should know how to classify. Another thing there should be, which we have not mentioned in this, there is not wasteful exercises for doing the PAP smear. We can also identify the infection and inflammations. So what are the infection and inflammations? We can also identify Even we can identify the HPV, we can identify the HSV, we can identify the trichomonas, even the other infection we can identify. So that is the very important method for the screening. So we can treat the infection, inflammations, and reactive and reparative changes due to the radiotherapy in this. So that should be very, and another important thing regarding the behavioral system, that there is a good cooperation between the pathologists, clinicians, and if anybody have any doubt regarding the cytology, they can send their report to other and they get the expert opinion.
Yeah, thank you very much, ma'am. So we will move on to next question, Dr. Dipti, which is the primary screening modality recommended nowadays. There is always a change in the recommendations. So initially it was a PAP, then came the VIA. Even the government set up, they trained the medical personnel for VIA testing, that is visual inspection with acetic acid. And now the trend is changing. So which is the primary modality recommended nowadays for screening?
As time passes, we have, as you said, 3 different methods now. First we had PAP, then we had VIA, and now HPV. So if we compare these 3, then I would say VIA and HPV stand on at par comparing to what you said, the best screening technique. It has a good sensitivity and a very good specificity. What is the highlight now for HPV testing becoming the primary consideration and the best method for screening being, it has a very high specificity and a very good high negative predictive value. Means when you say that the person is negative, the chances of being falsely negative be very low. So when we have patients getting lost to follow up, where we should consider these of not losing out a patient, then this HPV testing becomes very important in standing a high chance of being a good test with an excellent reproducibility and a very good objectivity. Meaning the flaws that pap smear has, where the reporting is a little bit subjective, the cytological reporting may not be up to the mark, they may not have updated. So when we said that, ma'am said, when the patient transfer from center to center and the report, because it's a repetitive test, if it doesn't become a good cytological reporting, then PAP loses marks there. So HPV testing therefore stands the best way because it is very objective. Either you have it or you don't have it. And then because the negative predictive value being very good, it can be easily reproducible. Again, it requires very low amount of testing and training required for conducting it out. The only negative it carries, it costs maybe as time passes. And once we finalize, as you said, the Fogsi GCPR has a very good guideline. Like in raw resource setting, we can use VIA because it is at par with HPV testing. Whereas in available resource setting, HPV becomes the first choice.
Right. So it is highly specific test with less sensitivity. But nowadays, this is recommended as a primary screening modality because we all know HPV is a positive agent for cervical cancer. What are the different methods that are used for HPV testing in short?
HPV can be done in India, LBC, that is liquid-based cytology. HPV is the maximal number of times we combine it with LBC detection, which is just had a cytobrush and very easily we can do it. Like for PAP, we need to do a methodical PAP test. Conduction is also important. Like for HPV DNA with LBC, it becomes very easy. Other hybrid capture tests are currently not available. And plus their cost factor also becomes important. Once we go higher and higher and targeted towards the targeted mRNA and protein detection tests, they are a little bit, not for low resource setting, and very selective number of population can afford or can avail to with these hybrid capture tests. But LBC DNA is almost easily available everywhere and can be quick accessed even in the comparable resource settings. So I think that is the better option. Other than
I just disagree with this because HC2 is easily available and routinely I do HC2. I don't do PCR testing, because HC2 is more reliable than a PCR testing. As you said, the sample collection is collector or the container is same. Once you take a sample for LBC, HPV testing is done in the same sample. Even if the HPV positive cases, they will do the genotyping for that in the same sample. So it is very convenient in that way. And CARE HPV actually is a very good test, having low cost, and the results are available within very short period, like 4 to 5 hours. But Unfortunately, the test is not available. Now it's the role of government to make this available so that we all will use it in our daily practice. So, Dr. Vani,
Dr. Bharti, I also want to say here that if the HPV test is positive, it does not mean that patient develop the cancer. So that should be very clear to them. They require the secondary and not do before the 30 years of the age. Start to doing after the 30 years. So if the patient has HPV infection, there are chances to reverse and they should be not bothering. And Dr. Priya has rightly mentioned about the HPV positive patients. The NILM also report is there. So we should follow the patients, and that if patient is not follow up, then we will see how to manage the patient. But if they are follow up, we can go for the follow up of the patients also.
Yes. So don't become panic if HPV is positive.
Yeah.
And don't do it in a patient of less than 30 years of age.
Yeah.
Start doing HPV after 30 years of age.
Yeah.
So Dr. Vani, which is the method?
Ma'am, Rahul sir is not available. He is caught up in an emergency.
Okay, so next, Dr. Monica Kalloli, I think.
Yeah.
Can you answer this? Which is the method recommended for low resource settings? And
So
how
for
it
for low resource settings, it is the best preferred method would be VIA. That's the method of choice, as it is very easy, and even a paramedics can do it once we train them how to see the cervix, get the cervix right. So that's the most recommended. And how it is done, it's basically like a routine per speculum examination. You put the speculum and apply acetic acid 5% to the cervix, the ectocervix part, including the transformation zone, the spermocolumnar junction. Apply whole thing, wait for a minute, and then see for the changes. So when we say the changes, what we need to observe, especially in a VIA, if we have to say it is a positive, then the white changes. Why it happens? Why it is because of the cellular. If the more the cellularity, the coagulation takes place, and then it starts turning white. So if it appears very fast and rapid, clear-cut margins, and it's a raised margins from the adjacent surfaces, then we say it as it is a VIA positive. Or like if there are very hazy, margins are not very clear, very opaque or light pale white structures, then they are usually towards a VIA negative this thing. And also, like as the WHO has said, because in the low resource center, a group where we are attending to, the attrition rate is very high. So not to lose these patients, they have taken up the approach of screen and treat immediately in the same sitting, without waiting for the histopathological diagnosis. So that is the approach we need to take. So we can best take it with cryo, which is a mobile unit and can be easily done in the same sitting. And also like the Ministry of Health, which has added up the operational guidelines, where they are moving towards the opportunistic screening to the population-based screening. I feel VIA is the best approach, and combine it with see and treat protocol.
Thank you. Thank you very much. VIA, the full form is visual inspection.
Visual inspection of acetic acid.
Yes. And acetic acid is 3 to 5%. That should be freshly prepared. Should
Prepared
be
within
applied
24
1 minute.
hours. Yes.
Yeah. And then you interpret the results of VIA. So as I said, 1 round of VIA testing will help you in detecting more than 50% of CI in 2 cases, more than 75% of CI in 3 cases, and almost 100% of cervical cancer cases. So in low resource setting, this is the test that is routinely used, and our government.
And as its sensitivity is very high, and the negative predictive value is also high when compared to PIPE. So it really becomes MM for that.
So it is comparable to HPV testing, and our government has included this in HCD program, that is the non-communicable disease prevention programs. So cervical cancer and VIA testing has been included in this program. So as you said, the results of VIA are interpreted. Sorry, I could not put the images for this. The results may be either negative, positive, or suspicion of invasion. For a lesion to say it as a positive, it should be very well defined. It should be in the transformation zone, or it should touch the squamocolumnar junction, and it should have either raised margins, or it may be a flat with a feathery or geographical border. So depending on that, we categorize it as a low and high grade, depending upon the lesion. And sometimes the acetovitis is seen in a Nabothian cyst, in cervicitis, but that should be considered as a via negative. So we have to study it frequently so that you can differentiate between the via negative and via positive. So suspicion of invasion, nobody misses usually the growth or anything. So in leukoplakia and in warts also, the testing is positive, and leukoplakia cases should be biopsied because there is high chances of malignancy hidden in behind the leukoplakic area. So this is about via. Again, the limitations, as you were told, training quality, then how the person is doing and how he is interpreting. Any lesion, somebody may say that this is a low grade, but Monica will think that no, this is a high grade lesion. So usually there is a personal variation. Yeah. Another thing is, when I started doing via, only visualization with naked eye is not at all sufficient. You are not able to see it properly. So what I usually do is I use a magnifying lens when I do a via testing, and that gives me a clear-cut idea. So looking with a naked eye, interpreting becomes a little bit difficult. Also, you have to have a very good light to visualize the cervix. And these via tests were mainly for primary health centers or to the periphery, where we all know the modalities of treatment or the things that are available to work for them. The light is the basic thing which is much needed for this via testing.
Yeah, rightly
Again,
pointed out. Yeah, Dr. Bharti, you have rightly pointed out that our government of India in 2016, they mentioned adopted via as a screening test. But what problem we are facing is still the screening program is so less in our country, because so many diseases, communicable diseases, they include in this diabetes, hypertension, everything. So via is diluted and it is not taken as a primary test. So sometimes it is even we teaches the paramedical staff the adaptations, and they are so much busy, Asha worker, they are not able to perform this thing. And regarding Dr. Priya has rightly mentioned out, and even Dr. Shankar Narayan, he has done a lot of work on the via plus HPV DNA test. After that, either you go for the via test and do the thermal ablation. Now everybody is doing the thermal ablation better than the cryo, if it is possible. Because so that is the way we screen and treat whatever we want to treat the precancerous lesion before anything via positive patient. Don't leave them. Either follow up the patients or treat the patients.
Yeah, screen and treat modality must be clear. And one more thing is, in postmenopausal women, where the transformation zone has receded inside, you are not able to interpret the via test. So don't do via testing in postmenopausal. One more thing is colposcopy, that is a visual inspection. We all know, which is very sensitive, cost-effective than cytology. And this is a test which is indicated in either LBC positive, HPV positive, or via positive cases. So what you should do next is advise colposcopy, because you can take a biopsy from that. You can treat the regions very confidently if you have a colposcope. If you don't have a colposcope, doesn't matter. You can go for cryo or thermal ablation if you feel that the lesion is fulfilling all the criteria of ablative treatment. So Monica, next question was for you. But
so which test is better for screening? You cannot define as one particular test universally. It again depends which is the population which you are catering to. Whom are you attending? Is it a high resource setting people, well-to-do family? Patients you're attending to, low resource patients you're attending to. How easily you can get their follow-ups. All these things consider. As I already told you, like if we are going to consider of the high resource setting population, then HPV would be the most ideal screening test to be adopted. In low resource, as we already mentioned, via would be the best option to take. And if we go take a comparison, if we say HPV, then it has got 100% negative predictive value, which makes it very, very ideal. But again, the cost factor comes in. So you would restrict it to the higher economic group. And like via, again, it has got a very high sensitivity and negative predictive value. It is better than PAP if you take the comparison between via and PAP. PAP, of course, because it needs, again, your laboratory, pathology, equipment, setup, and everything. So These two comparisons, if we take VIA and HPV for low resource and high resource respectively, would be the best choice according to me. And PAP comes in the third position.
Okay, actually this slide is very poor. Sorry for
Yeah.
that. So it was mainly for specificity, sensitivity, negative predictive value, and positive predictive value.
Positive predictive value.
We have already discussed. So, Dr. Vaidehi, would you like to conclude and move to the next?
Yes, we had very crisp and very to the point, some messages where people can take home with a very clear message. So to conclude, screening is of course the backbone of cancer prevention, and cytology is proven to be a very successful tool of secondary prevention. VIA and villi should be popularized for low resource setting, and we all must work towards it. HPV testing is definitely becoming the primary modality in high resource setting, and new tests like mRNA E6E7 would further clarify our management. And this is a very important point, even in the post-vaccine era, screening has to be continued. So this all of us must remember. So Bharti ma'am, we can move on to the next module, that is our vaccination primary.
Yeah, I just want to add one thing, Vidhi, that we have discussed about the screening program, whatever that we have a cafeteria choice, and you nicely mentioned each test in elaborate way. What I want to highlight that we have developed the app, mobile app SSNP, which is free of cost in a smartphone. And Dr. Priya has mentioned, forgotten to mention that it is launched on 15th of July in 2022. So everybody should open that app. Whatever the method you are doing the screening, please log in that app and you can send this app. This will be the great help to the how many women you have screening by the any method. So whatever the method you are using, whether it is via PAP, HPV DNA, everything is mentioned in that app. That app name is SSNP mobile app. So please use that app also.
Thank you, madam. Thank you for that.
Yes. So ma'am, these questions, the panelists would just offer randomly. Please feel free to pick up the question that you want to answer. What is the cause of cervical cancer, and can you please enumerate the types and their oncogenicity, because this is important for vaccination from vaccination point of view. Yeah, Brajwala, you want to take this?
Basically,
Yeah, go ahead.
Etiological factor, if we'll go, it is the multiparity, frequent intercourse, multiple sexual partners, low immunity. All these are the etiological factor or predisposing factor for cervical cancer. And there are multiple types of HPV virus, but particularly 16, 18, 6, 11, 13, and 31 and 33 are having more oncogenic potential. And out of these, 16 and 18 are having more oncogenic potential. So these type of virus, if we get in our DNA PCR or hybrid capture, we have to do proper follow-up after 6 months or 1 year.
So usually there are 100 types of HPV, more than 100 I can say, and they some cause mucosal infection, some cause cutaneous type of infections, and these are mainly divided in high risk and low risk type. So low risk is 6 and 11, which is a non-oncogenic and which is a causative factor for warts, and high risk is an oncogenic type, 16, 18, 31, 13. Actually there are 13 types, high risk types. And these cause not only cervical cancer, but they cause anogenital, oropharyngeal cancers and many low-grade lesions also. Whereas low-risk types, they cause genital warts, laryngeal papillomas, low-grade cervical diseases, and cutaneous site of infection, mainly on the commonly seen on hand and foot warts. So why this is important? For a point of prevention. We want to prevent this deadly disease, which is a very preventable. So the important and peculiar things about cervical cancer, mainly the causative factor is known, which is not the case in any other cancer in the body. But yes, cervical cancer, the cause is known, and that is HPV. So it can be prevented with the help of vaccines. And third, this can be detected in a pre-malignant stage, and all this can be treated very nicely. The pre-malignant lesions can be treated. So regarding HPV vaccine, these are, anybody want to tell about this? Yeah.
Yes. HPV vaccines one best thing about them is they are safe, well tolerated, and they are very effective, and they are available. So that could prevent most HPV related cancers. And we have to follow the recommendations, very clear recommendations of vaccines through to, even for the 9 to from 9, it can start from 9 years, and HPV vaccines made, we can see it is made by the recombinant DNA technology, and they are easily available, and it can be given to like girls before they are sexually active. So they are effective if you start young, before they are sexually active. So
Okay.
the
So,
thank you.
Next question.
Yeah, ma'am, can I take that?
Yeah, sure. What are the types of HPV vaccine and what are they indicated for?
So there are basically currently 3 types of vaccines which are available in the market. One is the divalent vaccine, then we have the quadrivalent vaccine, and we have the nonavalent vaccine. So bivalent is by GlaxoSmithKline, which the trade name of which is Cervarix, and it is mainly indicated for cervical cancer because it has 16, 18, the highly oncogenic types indicated for cervical cancers. If we look at the quadrivalent vaccine, it has 6, 11, 16, and 18. It has, apart from cervical cancer, some protection against vulvovaginal cancers. Even in boys, it is indicated it could prevent oropharyngeal cancers and all. And the recently launched nonavalent vaccine, it has a lot of oncogenic types of HPV covered. So it has a wider range of HPV viruses which is covered and offers greater protection, though the protection comes at a greater cost. So it is indicated again in the same subgroup of girls as well as boys. So both can get the vaccine. And the ideal age of vaccination is between 9 to 45 years, but the younger, the better. So we have to catch them young. And ideal time is before they start their sexual intercourse. So that would be a great help because it can protect the majority of the HPV viruses.
Yes. So I asked just about the indications. Is it only the prevention of cervical cancer? No, but there are cervical dysplasias, warts, etc. All can be prevented by the use of quadrivalent vaccine, which is effective against low and high risk both. The only thing is Cervarix, because as you told, it's a bivalent vaccine. So naturally, it is indicated only for cervical cancer, 16, 18 types.
About the timing of the vaccination, I wanted to add something. We keep telling our patients that ideal time is before they become sexually active, which is right. But 9 to 14 years is supposed to be the best time because that time the immunological response of the body to the vaccine is the best. So the ideal time first is 9 to 14 and second window is before they become sexually active.
Yes, and by the age of 9, 10, they are just visiting the pediatrician for their vaccination.
Yes.
So the pediatricians, they can take over and start vaccinating young girls for that. Not only girls, but boys also can be vaccinated. Yes. Recently, India has approved vaccination for boys. Till now, it was not approved, but in last month only the person told me that the boys vaccination has been approved in India also. So that is a good news for us. So
Dr. Bharti, I want just because if you want to the herd immunity in the societies, the male and boy and girl should be vaccinated because then we can prevent the if we only give the vaccine to the girls, then it is not develop the herd immunity in the community. Yes. So it is a very important if the boys are, because in Australia, why we have the long coverage of vaccine, because they have the license for the boys and girls in there, and the immunogenicity is that time between 9 to 14 years is the best. So that is the right time to give the vaccine, both the, and then definitely there is a decrease the cervical cancer load in the community.
It is, and it is a sexually transmitted disease.
Yeah, it is sexually. That's why that is important.
That's why
because I just want to mention, because when I did one of the awareness program, even nobody is knowing it is the viral infection. Even the teacher has said, how it is a viral infection? It is a sexually transmitted infection. Cancer can be. So this type of awareness we have to be.
That we have to create. Yeah. So the efficacy of Gardasil is almost 90 to 100%, whereas Cervarix has 90 to 94% of effectiveness. So now, when can we give the vaccine? Yes. Who is going to take this out of the dosage schedule?
the most effective time for vaccination of a girl it will be. Now, just Marathi madam had told that 9 to 14 years we will have to start in between 9 to 14 years, and we can give even before first sexual act, and then the vaccine can be given to any girl above 9 years of age and recommended for women of 9 to 45 years of age. And we can give the vaccine as a first dose for cervarix. It will be the 0, 1, 6, and for Gardasil, it will be 0 to 6 months.
And nowadays there are 2 dose schedule for younger girls less than 14 years.
Yes.
Are we following it?
Yeah.
Yes, 0 and 6 months is enough for female.
And for that, the dosage schedule is 0 and 6. When you are giving to the girls below 15 years of age, only 2 doses are sufficient.
Dr. Bharti, will you like to enumerate about the vaccine which we develop in our country? The 1st September 2022, our Health Minister, Mr. Jitendra Singh, with the Serum Institute of India, they have launched the HPV vaccine. And very soon it will become in the market within 2 or 3 months. And the cost is about 100, 200 rupees. And another thing which I want to just share with our panelists, that we discuss about the 2 dose and 3 dose, but the WHO expert committee SAGE have discussed about the single dose of HPV vaccine recipient with the 2 doses of HPV, and they come to the conclusion that the effectivity is the same, but the recommendation is still we are waiting. So if we have this thing, our own indigenous vaccine, Indian vaccine, which costs only 100 to 200 rupees, which is soon come in 1 or 2 months with the single dose, definitely we cover the large population.
Yes, it will not be 100 to 200. 2 days back only I had a conversation with these serum people, and they said it will be about 1,000 rupees like that. And
but even then we can afford them, because quadrivalent was costing 400 and nonovalent costs 10,000.
10,000 rupees.
Even 1,000 is okay, but
that is it is really an affordable and
accessible.
Yeah. By the next question,
It's single dose vaccine.
Single dose, they have doing a lot of research, SAGE, the group of the expert in WHO, and it will be also coming in but it is still we are waiting for that.
Vaidhi, would you like to take next?
Yes. So can someone please tell us about the safety of the vaccine? There are 3 sets, but you can take one by one. And what about the special population of pregnancy and lactating ladies? And what about boys? Who will take this, please?
Ma'am, can I?
Yeah, sure.
Yeah, so safety, according to whatever research we have till date, it is a very safe and effective vaccine. There are very few minimal side effects. There could be a low-grade fever or a local reaction. At the most pruritus, some redness, irritation and all, which can be very well tackled. So safety is not an issue. And as you said about the special population, pregnant women, we do not recommend it because we don't have enough data. Lactating females also we should try to avoid it, but Gardasil, they mentioned that it could be offered. Cervarix is a strict no-no for lactating females. And yeah, coming to the third part, I think we discussed boys. Definitely, as we have already taken a call that we need to give this vaccine to our boys as well, and this should be also included in the vaccination schedule.
Yeah.
Is not only for this, but oropharyngeal cancer.
The other advantages also.
But we need to sensitize pediatricians for this vaccination of boys, actually.
Boys, yes.
Yeah.
I think boys and girls both, because they are, the catching these population and they can give it at the right time, both males and females.
The only thing, as Madam has said, is the vaccine cost effective?
If we consider
very cost effective, we can't call it costly.
But whenever the patient comes to you and you tell her about taking the vaccine,
about how you counsel them.
The cost. So how you will counsel her?
Counsel them.
Cost doesn't matter.
Jaan hai to jaan hai. We tell her that.
I am telling my patient that rather giving an expensive gift on birthday, you can vaccinate your daughter. That is the best. give.
Definitely, definitely.
No, you should also get vaccinated, because now longevity 80, 90, you have a quality of life, and for your children, for your husband, you have to live. So why not?
It will cost less than your Pizza Hut.
Yes, that is the way how you should counsel.
Yes,
You
exactly.
carry the costly mobile with you. You are going to hotels. You are taking costly dresses and everything. And one idea what I give to my friend is gift the vaccine, first dose. Whenever you are going for the marriage or wedding, then
absolutely.
they are always in a, what should I give? She is having everything. Now almost everybody has everything. So what to gift her? So this is the best gift from a doctor. That will be accepted very nicely.
Very
So
nice.
give her first dose, and definitely she will continue.
Instead of pre-wedding shoot, we give them.
भारती, there is slogan which I have met कि मैं अपने जन्मदिन पर एक कन्या को निःशुल्क वैक्सीन लगवाऊंगी और अपनी शादी की वर्षगांठ पर 5 महिलाओं की जांच करवाऊंगी. मैं और मेरे 5 करवाएंगे अपनी जांच और नहीं आने देंगे नारी पे आंच.
Wow.
Very nice.
Very nice. That's really great. So we should not say that the cost is too. We must say it is cost effective, because we know the treatment, how costly it is. So it is better to prevent the disease rather than let it happen. So we must tell few things. Is screening of a lady mandatory before vaccination? This is a common question asked even by gynecologists. So suppose a lady comes to you at the age of 25 and she wants vaccine. She knows HPV. So she will say HPV vaccine. Yes, madam, first do my HPV testing and then only I will take. So screening is not at all mandatory before vaccination, because we have seen there are 13 types of high-risk viruses and she may be getting infected with any of the types. So screening is not mandatory before vaccination, but she should not skip the screening once she is vaccinated. That should also
should be continued.
Yes, continue screening either with any of the methods that we have seen. And vaccine is not a treatment of this HPV infection, genital warts or anything. That point should also be told to her. So, few things. Vaidehi, would you like to narrate them?
No, ma'am, please go ahead.
So what is this type of vaccine? It is not a live virus, but it is an virus-like particle. So definitely that vaccine is not going to cause the disease. They are very safe. The side effects are very minor, and they're potentially very effective in preventing the cancer. So you continue screening. We have this Fogsi GCPR guidelines. Anybody wants to just go through it? These are again types of vaccines and preferred age group, the strength of recommendations. I think our time is over. What do you say, Vaidehi? Should we continue or for this GCPR guidelines? Again, we have discussed almost all the things.
Yeah, we have discussed all the things.
Yeah, the dosage schedule. Only thing is in immunocompromised girls, that is very important. The girls who are HIV positive, then the recommendation before 15 years also, you should give 3 doses and not 2 doses for this HIV positive girls. Pregnancy, lactation, we have discussed. Then important thing is victims of sexual abuse. The girl, when she comes with a history of abuse to her, then definitely you must advise and continue with the same dose.
Can others mute, please? I request the panelists to mute themselves. Thank you.
And what about the women having abnormal screening reports? We have seen ASCUS, LCIL, HCIL. Should we vaccinate them or not? Definitely you can, because you don't know the type of virus she is infected with. So to conclude, I will say, to produce a cancer-free society, Screening and identification of high-risk groups is must and should be followed by each and every gynecologist. Think of cervical cancer as a sexually transmitted disease and try to prevent it. Then advise some behavioral changes to the lady, that is, ask her to limit the number of sexual partners. This is a special topic of discussion. So we must advise especially the young girls. They are coming to us mainly for the Myfi-Mizo tablets. So you have to advise them to limit the number of sexual partners, delay the initial age of sexual intercourse, avoid STDs, use of condoms, herbicides, etc. Avoid smoking, which is also a very important factor for cervical cancer, and promote the HPV vaccines at the right age, that is before, after 9 years and before 15 years. So, Madam, would you like to say something before we conclude?
I just want to say a few things that as we all know, the cervical cancer is a major public health problem all over the world, and WHO has focused, which Dr. Priya has also mentioned, about the elimination of the cervical cancer by 2030 and launched the global strategy. And the strategy which I have modulated, that the first zone is the green zone, that every girl should be vaccinated before the age of 15 years. So that is the most important thing. Then that is the yellow zone, that is the alert zone, because the HPV does not have any sign and symptoms. So every woman between the age of 35 to 45 years should be screened. Whosoever is there, whatever the complaint which you have rightly mentioned in your talk, that whatever the complaint, we have to screen each and every woman, because there is no sign of HPV. And there is big window period after the HPV infection to develop the cervical cancer, almost 8 to 10 years. So we have long period to identify the lesion and treat the patients. And third, come to the red zone, that is again, that according to WHO, 90% women, whosoever is diagnosed, screening is not sufficient. We are doing the screening, whatever the method we are using for the screening, that is not suffice. We have to follow up the patient, we have to treat the patient, then we can prevent the, because as you know, what are the challenges we are facing in our country? We have the big challenges for facing the country, the growing population, poor knowledge. Priyankur is here. He's conducting the public awareness camp. We need to aware the public regarding the HPV vaccine. We have, Dr. Priya has mentioned, only 2 to 10% people of 2008, the vaccine is licensed. But still only 5 to 10% is covered. Why? What is the reason? Why only 10 to 15% are screening? Why? So public awareness campaign is very needed of ours. And can you know, all over the world, the India is the largest adolescent group. So we have the growing population. How can we cover all the men? There should be school-based strategy, community-based strategy for the day. If we really want to keep the India cervical cancer Mukt Bharat, that is our slogan. Thank you so much for patience.
Thank you, Madam. Vaidehi.
Thank you so much, ma'am.
You want to comment or say something?
No, ma'am, we are running late, so let's
Thank you. So thank you all panelists. Thank you very much for your nice coordination and inputs. And once again, I thank the PAC committee for taking this cervical cancer topic for this webinar. Thank you. Thank you very
Thank
much.
you so much, PSC
Bharti and
this
Vidhi.
opportunity.
Thank you, Bharti and Vidhi.
Thank you, ma'am.
Wonderful session.
Thank you, ma'am. Thank you, Vaidehi, and expert comments by ma'am. Thank you so much.
Thank you, Veena ma'am. Thank you, Vaidehi ma'am and Bharti ma'am, for that excellent deliberation. I think we are running a bit late. We'll move on to our next panel. Our next panel is another interesting panel. It's on modalities of conservative surgical management of CA cervix. We have two brilliant moderators with us, Dr. Binal Shaha and Dr. Monica Gupta. And our expert panelist for the session is Dr. Ajabha. Can we have Dr. Binal's slide, please? Dr. Binal Shaha ma'am is a national chairperson of the IMA. She is a consultant gynecologist and laparoscopic surgeon. She has been practicing at Dwarkesh, Vadodara, Gujarat. She has been awarded with many awards like Inspiring Gynecologist, Wonder Woman of Vadodara, and many more. Welcome, Binal ma'am. We are looking forward to the panel by you. Our next moderator is Dr. Monica Gupta ma'am. Dr. Monica Gupta ma'am is a very, very active
member of the Public Awareness Committee. She is the West Zone Coordinator. She has been the HOD and Senior Consultant at Daksh Hospital, Alwar. And she has many awards to her credit. Welcome, Monica ma'am. Our expert panelist is Dr. Ajabrao Vasu sir. Can we have his slide, please? Practicing as a gynecologist in Chikhli since the past 22 years. He has been an ex-medical officer at General Hospital Khamgaon, ex-IMA president of Chikhli, also the ex-secretary of the Buldhana Obstetrics and Gynecological Society. We welcome you, Vasu sir. We have a very elaborate panel of consisting of 7 very illustrious doctors. Our first panelist is Dr. Preeti Sharma ma'am. Dr. Preeti Sharma is a senior consultant in OBGY at Cocoon Hospital, Jaipur. She is also the master trainer of Fogsi RAC and the recipient of the Dhira Award 2022. We welcome you, ma'am. Our next panelist is Dr. Brennan Tavares. He is a specialist in high-risk. He is a specialist in high-risk pregnancy management. He was awarded 2 gold medals for postgraduate exams in MD OBGY. Our next panelist is Dr. Can we have the slide, please? Dr. Professor Surekha Taide, ma'am. Madam is the professor and unit head at JNMC Savangi, Wardha. She is a teacher, trainer, guide, and mentor since the past 20 years. She is the chairperson-elect for the Fogsi Clinical Research Committee. Welcome, ma'am. Our next panelist is Dr. Jagriti Nagar, ma'am. Dr. Jagriti Nagar is the present president of SOG. She is a designate associate professor in the Department of OBGY at BMC Sagar. Also, an organizing committee member of the conference held in Sagar in 2016. Welcome, Jagriti, ma'am. Next slide, please. Our next panelist is Dr. Alka Agarwal, ma'am. Dr. Alka Agarwal, ma'am, is the director of Vimal Nursing Home. She is the chief medical officer at Jawaharlal Nehru Krishi Vidyalaya at Jabalpur. She is also the zonal coordinator for IMA Mission Pink Health, and she is the vice president of the Jabalpur Menopause Society as well as IMA Jabalpur branch. We welcome you, ma'am. Our next panelist is Dr. Neha Saraf. Dr. Neha Saraf is the secretary of the Ratlam OBGY Society. She is a consultant at Ankur Hospital, Ratlam, and she is an obstetrician as well as a laparoscopic surgeon. Welcome, Dr. Neha, ma'am. And our final panelist, last but not the least, is Dr. Ravindra Korat, sir. Dr. Ravindra Korat, sir, has had a special intense training in advanced infertility with PGD and PGS at Wings IVF Ahmedabad. And he is an infertility and IVF specialist. He's also been the youngest trustee in Dayanand Social Trust working for tribal girls. And he has an experience of almost 14 years. Welcome, Ravindra, sir. Over to you, Monica ma'am and Binal ma'am, for the further panel discussion. Looking forward to it.
Thank you so much. Am I audible?
Yes, ma'am, you are. Yes, ma'am.
Yeah, thank you so much. And with special thanks to Dr. Priyankur and Dr. Monica Umbardhan and Dr. Shatabdi. I mean, heartiest congratulations for this awareness and a lot of eye-openers today. So really enjoyed the interactive session. Dr. Monica ji, you are there?
Yeah.
Are you
I'm just
sharing
sharing
the screen? Okay, great. And it's really, I mean, we have an entire spectrum of expert panelists. So we'll learn a lot from them today. And we hope to make this a very interactive session because this is something which we have not much thought about, because whenever we talk about cancer, we think radical. Whenever the word cancer comes, the only thing which comes to our mind is removal of the organ. But here, a very interesting topic is given to us that we have to give conservative surgical management of the CA cervix. So may I request my co-moderator, Dr. Monica ji, to please start.
Good evening, everyone. Thank you, Dr. Priyankur and Dr. Monica, for giving me this opportunity to have a panel on modalities of conservative surgical management of CA cervix. As we all know, the CA cervix is becoming very common and it is mainly between the age group of 35 and 45 years. And what we initially used to do We just find some cancer and we used to do hysterectomy. But now there are so much of the delayed pregnancy are there, late marriages are there, and patients are still want to conceive. Now the importance of conservative management of CS cervix has come, and we have to do it because only gynecologists can do a conservative surgery. Whenever it goes to the oncologist, they always prefer to do a radical surgery. We are having my co-moderator as Dr. Beenal Shah. Our expert is Dr. Ajab Rao Vasu. And our panelists are Dr. Preeti Sharma, Dr. Brennan, Dr. Surekha, Dr. Jagrati, Dr. Alka, Dr. Neha, and Dr. Ravindra. Welcome all. And we all know the cancer facts. It is the second most common cancer in the world. And there are around 25 cases per lakh women. And global incidence is there are around 5 lakh new cases per year throughout the world. And we are the 1/4 contributor of it. There are around 2.5 million deaths due to cancer cervix in India. And when we see the scenario in India, the Tamil Nadu, Pondicherry, and these areas having more than 20 cases per lakh women. And when the world scenario is seen, we are having around less than 33 cases per lakh women. So it is our responsibility to deal with it because conservative surgeries are very important. They are going to preserve the fertility if the patient is infertile, because the cure rate of the cancer is very high. If it is detected very early, that is between 90 to 100%. And she has to live a long life of infertility associated with grief, depression, psychological dysfunction, which is affecting her quality of life. So we have to give her option for conservative surgery, but careful counseling is very important for that. Dr. Beenal.
Now we directly come to the, thank you for the overall outlook. And may I request our first panelist, Dr. Preeti ma'am, to please look into this question. In your gynec OPD, there is a 35 years second gravida with a 1 abortion, and she complains of white discharge per vaginal. And the pap test, I mean, I hope that all of you are doing pap test for your patients. The pap test shows dysplasia. So how will you manage this case further? Dr. Preeti ma'am. If Dr. Preeti ma'am is not ready, I think Dr. Brennan, you can take up the case.
Yes. What is the gestation, madam, of this patient now?
Right now, the patient is like she has detected the UPT positive.
Okay. Now, most of the PAPs now are reporting in the Bethesda system. So if it is dysplasia, let us classify them as mild dysplasia and moderate and severe dysplasia as the second category. So mild dysplasia, you do absolutely nothing. These patients normally don't progress, or you just treat them like normal patients and follow these patients up post.
So will you do any further investigation, Dr. Brennan, or you are just happy with the pap smear?
Oh, no, madam. If it is a moderate to severe CIN, then definitely she would require a colposcopy and frequent monitoring, probably a 6 to 12 weekly colposcopy, just to see that there is no worsening of the dysplastic changes. And if there is any suspicion of any progress, then you would like to take a small biopsy, though biopsies in pregnancies are generally avoided. A small biopsy of less than 1 centimeter, if it is really indicated, is not harmful.
Right. And it is very important that, colposcopic guided biopsies are more accurate, and you take it from the squamocolumnar junction. And it is like, it gives you a tissue diagnosis of how to deal with this patient. Right. So now what is the treatment for CIN option? Like, what are the treatment options for CIN?
Now, for this patient?
Yes. It's it's just a dysplasia.
No, if it is a mild dysplasia, I would not like to do anything in pregnancy. I will just follow her up.
Okay, wonderful. You will just follow up the patient.
Yes. There is absolutely no treatment to be given for a mild dysplastic change.
Right.
Whereas if she is a severe dysplasia, even if she's a colposcopy shows changes of dysplasia, I
Right.
still wouldn't do anything for these patients because CIN2 takes a lot of time to progress into cancer also. So this patient also can be followed up postnatally if there is no progression.
Right. But in case if you want to treat, like the patient is, more worried about the dysplasia, not about the pregnancy, and she wants some treatment. So what are the options which we have?
See, so CIN, I mean, the only option what we have is basically only a cryo or a laser, but I would still avoid them because I would reassure them that even though she's mild, I'm still following her up with colposcopy. I don't like unnecessary investigations in pregnancy and treatment unless they are really indicated, because the cervix bleeds in pregnancy. So you have to be very careful before manipulation.
Yeah. So
You have
thank
to
you
be
for
certain
that
that is
important
really required.
message, Dr. Brennan. You are actually a perfect panelist for this panel where we really want a conservative management. But finally, we decide to do a cryotherapy. So Dr. Alka, could you elaborate about like what exactly is cryo and how it would work for a CIN case?
In cryotherapy, hello. Yes. Good evening. And first of all, I am very much thankful to Dr. Priyankur and Dr. Monica for giving me this opportunity to appear in this webinar. And the treatment option, cryotherapy, you're asking about cryotherapy. In cryotherapy, yes. The tissues are frozen with cryogun, and 5 minutes, the cryogun is applied over the cervix.
Monica ji, please change the slides.
The cryogun is applied over the cervix, and the freezing is done till for 5 minutes. So it will kill the abnormal cells.
Okay. But what are the disadvantages?
Because tissue is destroyed, so we will not get any sample for the biopsy. And so invasion, how much the sin is invaded cannot be diagnosed. And it is not appropriate for the large lesions. Small lesions can be treated with cryosurgery, but not the large lesions. And endocervical lesions also cannot be treated with the cryo.
Right. And what are the likely complications? Like already, I mean, Dr. Brennan has already mentioned few of them.
Bleeding, because it's a pregnant cervix, it bleeds easily. The bleeding will be there, and then infection, then vaginal discharge will be there. And sometimes abortion can happen.
Okay. So what are the other options? Like Dr. Surekha ma'am, you are there. Like what are the other options to this? Like suppose we don't want to do a cryo, then what else can be done for a CIN? One option is laser, as Dr. Brennan had already mentioned.
Ma'am, Surekha madam
Dr. Surekha ma'am,
she's not there, ma'am.
Okay, she's not there. Okay, Dr. Jagrati ma'am, are you there?
I think she's also not there.
Okay. So then I think Dr. Ravindra sir has also left. Dr. Neha ma'am, are you there?
She's also not there.
Okay.
Only
So
we are
then
left with the two panelists.
So then finally we have Dr. Alka ma'am and Dr. Brennan sir, and our expert Dr. Vasu sir, are you there?
Yes. Yeah, madam, can I comment on this?
Yes, please, Dr. Brennan, please.
Madam, I would be very, very uncomfortable to treat a CIN patient with treatment modalities, even though it is a mild treatment modality, because CIN is really harmless in pregnant patients. You are just waiting for the postnatal period to treat these patients. I would use all these modalities in the postnatal patient if my colposcopy does not show any progression of even CIN1 or CIN2. Why? Because there are certain risk factors when you do these procedures, and the risk-benefit ratio, if you are doing it as a complication for the pregnancy, since there is no much risk of CIN2 or CIN3, since you are monitoring these patients, I would definitely avoid these procedures in pregnancy. Whereas
okay, perfect.
Post-delivery, you can.
Now, yeah, imagine this patient is now postpartum and she has come to you, and suppose you want to do a leap.
Yeah, if she's postpartum, then I would be more comfortable in colposcopy as see and treat. So I would be more comfortable rather than a cryo. I would get a tissue biopsy. I would do a low loop excision of the transformation zone.
Okay, so can you just describe, what exactly is LEAP? Like, how do you go about it?
Yeah, so what you do is you take put a patient under colposcopy. You can either do it with acetic acid or you can use Lugol's iodine. With acetic acid, beautifully, we have heard how the aceto whitening takes place. So you take the white areas, and if it is Lugol's iodine, usually the abnormal cells will utilize all the glycogen. So there is no glycogen to be stained with Lugol's iodine. So the unstained areas would be the main areas where you're going to take a biopsy. But if the biopsy report then comes as a CIN2 or a CIN3, I would definitely do a low loop excision where you have a loop wire. Today you get insulated speculums also, which are available for a low loop excision. You take an insulated wire and you just remove the entire transformation zone. Again, post removal after hemostasis, you can use a ball cautery or cautery machine. You can, keep seeing and treating the patient in the same sitting where you reapply Lugol's iodine to the residual amount of cervix and see. You can get a bit of, it's the best way to treat a CIN2 or a CIN3 because you have got a full specimen. The only problem with loop excision is that you'll not be able to comment on the margins because the margins are electrolyzed because it's electrocautery. So if there is an actual malignancy which was hidden and you want to know the borders, you will really not be able to make out the borders. That is the only loophole. Otherwise, for a pure CIN, low loop excision is my favorite treatment.
Okay, and what are the advantages and disadvantages of the same?
The advantages is that it's you don't need a very large learning curve. It's very simple. You just have a loop, you have a cautery, and you have a speculum. That is more than enough. You get a full-blown specimen. You can treat the full lesion in one sitting because you can keep doing the excisions in a single sitting. And the only disadvantage probably is that you don't get the margins cannot be commented on if it is an actual invasive lesion is present. Bleeding can be a complication, but then that bleeding usually really doesn't trouble you because you are anyway using a cautery in this sitting.
Monica ma'am, please change the slides.
Acha, theek.
Okay. Yeah, so complications you have already discussed, severe bleeding and burns and all. And long-term complications in this patient, Dr. Brennan?
If you do too much of an excision, then this patient can basically land with a cervical incompetence in pregnancy, can sometimes land with cervical stenosis also. So, I mean, you can have problems, the Nebogen cells and the cervical mucus cells get affected. So the cervical mucus can be affected in these patients. But no major serious complications basically with the low loop excision.
Yeah. Next slide, please. Yeah, so basically what is important is that the entire transformation zones should be excised, as very well said by Dr. Brennan. And this is a comparative assessment between the cryo versus LEAP, where the effectiveness of LEAP is much more, but the complications can be like bleeding and you might require some kind of anesthesia, especially if the patient is not comfortable. But the best part is that you are getting a tissue for the histopathology, and the cost may be slightly high, but I mean, it is up to us how to, negotiate with that. But the learning curve is small, as very well said. So, Dr. Vasu, any expert comment on this case? We would like to hear from you. Dr. Vasu, sir?
Vasu, sir, are you there? He's just gone offline. I will call him, ma'am.
No problems. And then till then, Dr. Monica ji, please continue with the next case.
I think Dr. Neha is also there.
Yes, ma'am.
Is Dr. Neha there? Our second case is patient of 35 years visiting the gynae clinic complaining of irregular bleeding PV. Her pap smear showing malignant cell and on CECT grade 1 CS cervix was diagnosed. She wants to preserve her fertility. Now, how will you going to manage? Dr. Alka, please, you will take the answer.
First, we have to evaluate the patient, the primary lesion. We have to evaluate the primary lesion as well as the potential site of spread. And if it is limited, if it is only limited to the cervix, it's one stage 1A and 1B, then we can do the fertility preserving surgery, which is like trachelectomy, which we can do the trachelectomy operation. Or if it is in that we can trachelectomy. In trachelectomy, the cervix is removed with 2 centimeters of the vagina, and a small part of the cervix is left attached to the uterus. And then afterwards, this uterus is stitched to the vagina, A surclage is applied with the permanent muslin tape or silk tape. A surclage is applied with the knot posteriorly over the cervical part of uterus. So this is a radical trachelectomy operation.
Ma'am, we can go for the conization also. We can first go for the conization. That is much simpler way. It is simple dysplasia. It's a CML. We have to go for the lymph node dissection also along with it. If the lymph node is involved, then we are not supposed to do any conservative surgery. If lymph node are not involved, we can go for the conservative surgeries. And the lesion should be at least less than 2 centimeters for going to for the radical trachelectomy. And we have to explain her and counsel her properly. What are the going to be, if the lesions are more, she has to go for the radical surgeries also. And if needed, we can go for the oocyte preservation or ovarian preservation, or the ovary can be transplanted for the future pregnancy so that she can go for the surrogacy. Brennan, sir, you will tell about the conization for these patients?
It is only in stage 1A, A1, where your depth of invasion is less than 3 millimeters, that you can do a conization. Now, it is found that if depth of invasion is less than 3 millimeters and your lymph vascular spaces are negative for the malignancy, then the chance of lymph node metastasis is less than 1%. So a simple conization procedure, a cold knife conization would be far better, where you excise, depends on the size of the transformation zone. You either take a broad base cone or a short base cone with a deep apex, and you send the cone for testing. Now, if the testing shows that the margins are absolutely negative, and she is a true stage 1A without any lymph vascular invasion, that completes her treatment. She only needs follow-up. She can get pregnant. There is no need of a cervical stitch in a conization which is done. But however, if the lymph vascular spaces are positive, or if she is a stage 1A2 where it is gone beyond the 3 centimeters, but less than 2 centimeters, up to stage 1B1, you will have to do a radical trachelectomy from above. An abdominal radical trachelectomy, where you remove the entire cervix, you remove the upper 2 centimeters of the vagina, you do a pelvic lymphadenectomy also, and you also remove the attachments of the cardinal and the your McEnroe ligaments. You don't need to remove the whole of them. You just need to remove the uterine attachments, and that serves the purpose. And if the lymph nodes are negative, in which most of the cases, because the lymph node metastasis in A2 is roughly around 3 to 8%, whereas the lymph node metastasis in B1 and B2 is right up to 20%. So lymph node biopsy is your pelvic lymphadenectomy is extremely important whenever the lymph vascular spaces are there, combined with radical trachelectomy. But when you do a radical trachelectomy, you have to explain to the patient that pregnancy rates are not 100%. The pregnancy rates are just 60 to 65% with a take-home baby rate of 55% only. They do require a permanent cerclage in these cases, where you do the cerclage in the same sitting as the trachelectomy.
So first, the foremost thing is, where you have correctly said, is a lymph node dissection. If we have to send for the frozen section, if the frozen section is positive, then we have to abandon the procedure. We should not do it. And if it is positive, if it is negative only, then we are doing it. Initially, it was done by the Darjan and it was done vaginally. Now we can do abdominally also, laparoscopically also, or with the robotic surgeries also. And if the cancer, it is an unfavorable type of histopathology, like small cell CA cervix, adenocarcinoma, neuroendocrine cancers. So in these, prognosis is very poor and we should not do these type of things. And the recurrence rate is almost similar as that of the radical surgeries. It is less than 5%. And we should not go for the neoadjuvant therapy, chemotherapy for these type of the patients, because there's a gonadal toxicity and they want fertility. So there's a chances of ovarian failure. So we have to keep these things in mind. We should only go for the surgical methods, not for the radiotherapy and the chemotherapy in these type of the patient. And pregnancy outcome, the conception is around 80%, but live birth rate is 65% and preterm labor is around 28%, and we have to counsel them before they are going to have a preterm labor or a late abortions, and we have to be very careful about it, and we have to give a prophylactic antibiotic during the pregnancy to prevent the ascending infections. And a most important thing is we have to go for a classical cesarean section. We should never go for the lower segment cesarean section if the patient is going for the delivery. So it is a good option for the early stage detection of the patients who are desirous for the future pregnancy, but we should be very careful about the selection and counseling of the patient. Next question. Dr. Ajab Rao is not there, no? For the expert comment? Yes, sir. Sir, for the expert comments. Sir, expert comments on this case. The question is we were having a case of 35 years old lady coming to the gynae clinic complaining of irregular bleeding PV, pap smear showing malignant cells, and CECT is showing grade 1 CA cervix, and she wants to preserve her fertility. What?
Trachelectomy is the choice of surgeon.
Okay.
Yes, sir.
Okay, thank you for those expert comments. Yeah. So now we come to the last case scenario. Here we have a 32 years female at 20 weeks of gestation. She is coming for regular antenatal checkup, and her pap smear shows LSIL. So so first I would like to ask the gynecologist here on panel that are you doing regular pap smears during pregnancy? I mean, what are the recommendations and what is your, daily routine?
I do it only at the first visit.
Okay, wonderful, Dr. Brennan. What about you, Dr. Alka, ma'am?
No, I'm not doing it regularly. If patient is having infection or cervix is bad, then only I'm doing the pap smear.
At least you are putting in a speculum, right? So visually,
Yes.
at least you are inspecting. So this
Yes.
message I want to give to everybody that at least, take the effort, because nowadays it's a, era of transvaginal sonography. So, we don't just have a speculum and at least have a look at the cervix. That is most important. And ideally a pap test is recommended, because 1/3 of cervical cancers happen in the reproductive age group, and 3% cervical cancers are diagnosed during pregnancy. So one case of CA cervix may happen in every 5,000 pregnancies. And luckily and good for us that 76% of the lesions which are diagnosed during pregnancy are in early stage. So we can give them a conservative management. So this is a very good time if we can pick them up early.
And madam, can I comment on one thing?
Yes, please.
Yes, and now these are the statistics of the people who were in the younger days, probably in the 80s and 90s. Now going forward with adolescent girls being sexually active, these cervical cancers will be far at the earlier age group. So
you are right.
So probably 10-15 years down the line, you'll have a great the percentage of early cervical cancers will be far greater, because you have got HPV infections right from 14, 15, and 16 years now.
You are very right, Dr. Brennan. Thank you for that clinical insight. And such patients most commonly present us with irregular bleedings, PV, and cervix normally becomes of a triple size by the end of the pregnancy, and especially the transformation zone becomes exuberant due to the eversion of the squamocolumnar junction. And this may be confused. It may look like an abnormal growth and may be confused with the neoplastic lesion. And there are certain cytological changes which happen naturally during pregnancy. There is a glandular hyperplasia because of the presence of decidual cells. There is the Eryas-Stellas reaction. The immature metaplasia may be confused with the cellular atypia by the pathologist as well. So there are sometimes false positive reporting also done. Next slide, please. So colposcopy is a very good investigation, especially whenever in doubt, try to do in the colposcopy. The increased vascularization of the cervix could be happening during pregnancy, but you can see very well the reaction of the metaplastic epithelium to acetic acid, as just now told by Dr. Brennan, that you always have those stains and staining techniques So you can, your suspicion can become more strong. And whenever in doubt, a colposcopy guided or a staining guided biopsy will be more sensitive. Next slide, please. So this is how it would look. And the sensitivity would be around 83%, and the specificity would be 95%. Next slide, please. And Dr. Neha ma'am, if you are there, you may also please join. So I would like to ask Dr. Neha ma'am that if suppose you take a cervical biopsy during pregnancy, what are the complications which are expected? Dr. Neha ma'am, are you there?
Ma'am, I think she's left now.
Okay, fine. Yeah, so as already told by our previous the panelists that cervical biopsy during pregnancy can lead to bleeding. At the same time, this patient may have a chances of preterm labor or an abortion or a rupture membranes. Next slide, please. So what imaging techniques can be used during pregnancy? Dr. Brennan.
My imaging technique of choice for a CA cervix anyway would be an MRI compared to a plain CT.
Okay.
So CT, yeah. Now today you have got a low resolution. I mean, CTs which give you very low dose radiations, which are quite
exactly
sensitive. Yes, but comparatively, if you ask me, even though they are low resolutions, my choice of imaging still would be an MRI.
Okay, to see the extent of spread and everything.
Yes.
Okay. And the dose which is allowed due to the fetus is 10 CGY, and we do have, as very well said, that we have CT scans which can give low radiation as well. Yeah. So next slide. Now, what is the management plan? Like suppose you get a precursor lesion, like it is, a very, very early case. Then obviously, what are you going to do? Dr. Brennan, can you summarize this? Because you already actually have done. Yeah.
Yeah. So you mean to say she's gone beyond CIN and she's gone into invasive cancer?
So I'm going to give you all spectrums. So suppose you have a very early precursor lesion, then obviously what are you going to do? This is a repetition of what you already said.
Yes. If it is a precursor lesion, just don't bother. Just follow this patient up on colposcopy. Only if you have a high index of suspicion of a progression, take a biopsy and confirm that it is not. But reserve biopsies only when indicated, because cervix manipulation in pregnancy can be quite tricky. You will get bleeding, and once bleeding starts, you will be then taking more and more stitches to stop the bleeding. It can precipitate labor. It can precipitate a lot of other complications.
Right.
So my principle is basically don't touch the cervix until and unless it is really required as far as biopsy is concerned.
Right. And as you already said that some lesions might regress, like you already said.
Most of the patients, even on HPV 16 and 18, more than 50% of them regress within 1 or 2 years. I mean, it's only around 10 to 15% which usually progress to CIN1 or CIN2. So you don't have to worry if it is HPV also, or if it is a CIN1 or CIN2. Even 60% of CIN2 and CIN3 regresses back to normal over a period of 1 year. That's the reason I am very comfortable not doing anything in pregnancy. It's just a matter of another 6 to 7 months to go. So most of them are usually comfortable. Postnatally, yes, at 4 weeks to 6 weeks, I would redo a colposcopy and if required, a biopsy at leisure.
Right. So it also matters, how you explain to the patient. Because the moment if you use the word cancer, patient is going to get terrified. So as Dr. Brennan, like your body language has to be so confident and comfortable, and you yourself should be explaining with a conviction that this is what you have, and most probably this is the treatment protocol, and we are going to follow it like this. So it is very important that how you explain to the patient. So Alka madam, in which patients you would like to go for a conization? Can we go to one slide back? Yeah, this.
If high grade lesion is there, or when colposcopy is unsatisfactory, when that means the whole transformation zone is not come under the colposcopy examination, and then conization can be done.
And as already discussed previously, that we will try to postpone it till postpartum.
Yes.
But only if very suspicious, then we'll do it preferably between 14 to 20 weeks. But at the same time, preferably endocervically, we will not, intervene.
Endocervical should not be done. Yes.
Exactly. Yeah. So next slide, please. So basically, the treatment of invasive CA cervix depends on 3 things. First is obviously the gestational at the time of diagnosis, the gestational age. Second is very important, the stage of the disease and the size of the lesion.
right? And the patient's wish to maintain the pregnancy and the fertility. So these three things combined will, guide you that how to go further. And as already said by our worthy panelists, that colposcopy you can do regularly, monitor and follow up the patient, reevaluate, and biopsy only if the suspicion is very strong, or else go ahead postpartum. If there is no evidence that pregnancy will accelerate the disease progression. Again, survival doesn't depend on the trimester at the time of diagnosis, and postponing the treatment for fetal maturity will not affect the recurrence rate. So there is the evidence there, right? So Dr. Brennan, once again, I would like to have comments from you that here we have a case, we have invasive carcinoma 1A, 2 or 1B, and this is diagnosed at less than 20 weeks. Then, what would your say?
See, when you have an invasive carcinoma in less than 20 weeks, I would first like to see the parity of this patient.
Yeah.
Now, if she's a gross multiparous patient,
exactly.
She still comes into the category where termination of pregnancy can be offered to this patient, because her life and her children earlier are far more important than continuation of this pregnancy.
Exactly.
So you terminate this pregnancy and treat her as a non-pregnant patient, what you would have done, like how you would have done a radical hysterectomy for her with a lymph node biopsy. I mean, the lymph nodes, all the lymph nodes, pelvic have to be removed. And if frozen section is available, get a lymphadenectomy first. Remember, lymphadenectomy is always done first because you want to get a frozen section sample. You do not want to land with a situation where you have done a complete surgery and then the lymph nodes come positive and this patient has to go again for radiotherapy.
Right.
So if the lymph nodes come positive, the first thing you do is abandon the procedure and just give post-operative radiotherapy to this patient. If only the lymph nodes come as negative, you go in for a radical hysterectomy and continue. The problem comes if she's a primary gravida.
Right. Next step is, and suppose the pregnancy is more than 20 weeks.
Yeah. If she is primary gravida and if she is less than 20 weeks, then the pregnancy becomes precious because she will not be willing for termination of pregnancy.
Right.
But under such a circumstance, the lymph node sampling becomes extremely important. So you have to do a abdominal lymph node sampling before 20 weeks of pregnancy. It's not difficult to do before 20 weeks of pregnancy. It's only after 22 weeks of pregnancy that a lymph node sampling becomes very difficult because of the gravid uterus.
Right.
If the lymph node comes negative, that means she is still in the early stages. Then during pregnancy, since she is less than 20 weeks, you have got two options. See, cervical cancer management in pregnancy, there are no specific guidelines for given out because you have got options. You have to give the option to the patient.
Yeah.
Your one option could be after a pelvic lymph node sampling which has come as negative. You can do a radical trachelectomy for this. I mean, not a trachelectomy, but you'll have to use you'll have to remove the cervical mass. Can be removed. A localized surgery can be done where the cervical mass, along with 1 centimeter of normal cervix above the mass, is removed. The patient has to understand that this is a procedure which is associated with risk factors. Your option number 2 is if she doesn't want to do this, then you can continue the pregnancy, postpone her treatment till fetal maturity is achieved, do a classical cesarean section, and then do a modified radical hysterectomy with lymphadenectomy at the same sitting. That completely completes her treatment.
Right.
But in the meantime, during follow-up, when you are following this patient up, if there is evidence of progression, then you have a concept of giving this patient a neoadjuvant chemotherapy to stabilize the tumor before she reaches lung maturity. So you can give this patient a single agent of a carboplatin, or probably you can combine it carboplatin with your paclitaxel, and you give it at 3 to 4 weekly intervals, not before 14 weeks at any cost, because these have high incidences of abnormalities and abortions.
Yeah.
So after 14 to 16 weeks, you can offer her neoadjuvant chemotherapy if the tumor progresses. Continue it, but see to it that you don't give it in the last 3 weeks prior to delivery, because you do not want fetal bone marrow suppression taking place during post-delivery. So your last course should be 4 weeks prior to your planned delivery. My neonatal setup is very good, so I would take these patients to maximum 32 weeks, deliver them at 32 weeks by giving them steroids. At some centers, you can continue to 34 to 36 weeks, but the postnatal care, when you are going to terminate, depends upon your pediatrician and your neonatal backup. And then do a classical cesarean section and do a modified radical hysterectomy and go ahead from there. If you get any positive, high risk positive signs, that means if you have a parametrial invasion or if you have a lymph nodes positive, or if you have got anything, you then have to give her post-operative radiotherapy.
Yeah, very well summarized, Dr. Brennan. Dr. Alka ma'am, what would be the route of delivery in this patient? Like suppose we have progressed and we are waiting, and now how do you plan to deliver?
The delivery is possible and it is safe also. So in early cases, and if it is advanced, if it advanced disease, then cesarean is to be preferred.
Yeah, exactly. So obstetric, apart from obstetric reasons, like suppose it's a preterm and all, obviously all of us would prefer a cesarean. But in case of a term baby, vaginal delivery in early lesions is okay. And there have been some queries related to whether the disease would progress by lymphovascular dissemination during the labor, or whether there would be chances of implantation at the episiotomy site. But such, queries have been busted. And as of now, vaginal delivery can be done, but only in cases of CIN and early stages. Otherwise, a cesarean is obviously preferred.
My choice of delivery, even for a stage 1A1, would still be a C-section.
C-section. Okay, great.
Well,
and obviously, in
can...
preterm babies, we would like to go for cesarean as well. Yeah, so over to Monica ji, and thank you for your inputs. Excellent insight.
Now, what about the prognosis of the mother? Brennan, sir? In the case when we are treating with the patient of the CA cervix.
In stage 1, the treatment is usually complete. So we have got an excellent prognosis with 5-year survival rates in excess of 95%. Whereas in stage 1A and stage 2, if it is picked up well and you have managed this patient well, and your histopathology, important is post-delivery histopathology on the specimen which comes. If your margin, if your parametrium is negative, if your lymph nodes are negative, and it is strictly restricted to stage 1A1, then you have got 5-year survival rates of even 85 to 90% in stage 1 B1 also.
And in the pregnancy, we can easily diagnose the cases because the colposcopy is more sensitive at that time because of the changes. So we can pick up the early cases also.
Yeah, only thing is when you're doing a PEP test, majority of the cases come as low-grade squamous intraepithelial lesion, not because they're having low-grade squamous intraepithelial lesions, but a pathologist reports them because of the normal changes of basal cell hypertrophy and glandular hyperplasia, which take place under the estrogen hormones.
Alka ma'am, what will be the fetal prognosis?
It depends upon the gestational age. If it is and the stages of the cancer also. If it is 1A, then the prognosis is good because we are waiting till the postnatal period, and and we have to give decadron and or beclometasone for the lung maturity between 24 to 32 weeks, and if
we are giving the chemotherapies, then it will be a toxic effect to the fetus. It can cause in the early, if it is given in the early stage, can cause the congenital malformations also. So we should not give, and it can lead to the low birth weight babies, IUGRs, because of the so much of the stress of the. If we tell to the patient she is having something like CIN or cancer or something like that, she's in so much of the stress and tension, and usually it is in the late stage of the. When the patient is very comparatively elderly, around 35 years of age, already she is having multiple problems. So it can affect the baby prognosis also. So in the last, I just want to say that nowadays we are going to get more of the cases because the diagnosis facilities are very good and we can detect in the early stages. So the importance of the conservative treatment is very important. And even in the pregnancy, we will find many of the patients are having the cancers because we are doing pap smear even in the pregnancies. Initially, many times when we were students, we were not doing it, but now we are doing it each and every patient who is coming to us.
So when the diagnostic facilities are high, so we can diagnose the things in the early stages and we have to treat. So the conservative treatment becomes very important. And I will ask if Dr. Azab Rao is there for his expert comments. I think, sir.
Yes, madam, you have said a good thing that we should diagnose the pre-cancer lesion in early. As we know, the mortality and morbidity is high with advanced stage. So we should diagnose a pre-cancer lesion. Today, we have more modalities to diagnose a HPV test, pap smear, colposcopy. So that is most important to diagnose pre-cancer lesion. Already Abhankar madam has said that while seeing patient in OPD, we should see the cervix with with acetic acid. So we can diagnose a high-grade lesion. We can't miss high-grade lesion. That is the most important thing. We should not miss high-grade lesion. So that is most important to diagnose a pre-cancer lesion, because advanced stages create more problem. Today's
secondary prophylaxis is more important.
Yes,
when we are diagnosing the cancer and we can treat it early, the survival rate is around 90 to 100%.
Yes. Awareness.
Good quality of life.
Awareness is most important.
I think we all gynecologists are very well aware of the doing pap smear and doing colposcopies, and most of us, I think we are doing colposcopy day in and day out, and it is very easy procedure, outdoor procedures. We can just put a speculum, see through the colposcope. I think we can diagnose most of the cases in early stages. What is your opinion, sir?
Yes, awareness is most important, madam. I have seen here, I have make available HPV test. There are 30 to 40 IMA members ladies, but not a single lady has done HPV test. So we should have to start awareness from our home. That is
exactly. Yeah, just like charity begins at home, the awareness has to begin at home. And actually, I would not like to have a raise of hands, but every gynac should ask himself or herself that when was the last time she got her pap test done, or for the male gynacs, when you did the pap for your wife. So, I mean, it has, because once we do it with a conviction, we'll be able to guide our patients better.
Now, good modalities are available like HPV test. So we should have.
Sir, I think HPV test is quite expensive. So we can just do a visual inspection with acetic acid, or we can do a colposcopy.
Yes,
that is costing less to us. And that can easily be done, and we can get the result on the spot.
In interior or Tahsil plus VI is the best. But we like gynecologists, we like IMA members, we should do HPV test.
HPV test we can do for the patient who can afford.
Yes, right. So I think we can conclude. Yeah, so thank you, Monica Gupta ma'am, for all the support. And thank you, Dr. Brennan and Dr. Alka ma'am, for being very proactive and having an excellent interaction. And thank you, Vasu sir, for your excellent tips, expert comments and all. Thank you so much. And thanks again to Dr. Priyankur and Dr. Monica Umbadan.
Thank you, Dr. Beenal. Thank you, Dr. Monica. And thank you, Dr. Brennan and Dr. Vasu.
Thank you, ma'am.
Thank you so much.
Thank you, Monica ma'am, Beenal ma'am, Vasu sir, and most of all, heartfelt gratitude to Alka ma'am and Brennan sir for being really, really proactive and taking up all the questions and for an excellent deliberation. I would now like to call upon Vaidehi Marathe ma'am to give the vote of thanks for today.
Yeah. Thank you so much. Am I audible?
Yes, ma'am. You are, ma'am.
Yeah. Okay. So hello, everybody. As we come to the end of this event, I, on the behalf of Fogsi and PSC and Amogs PSC and Fogsi YTP committee, I take this opportunity to express my sincere gratitude to all those who made this event possible and successful. First and foremost, a special word of thanks to our chief guests, President of Fogsi, Dr. Rishikesh Pai sir, Guest of honor, Dr. Jaideep Tang sir, Dr. Rajendra Singh Fardesi, Dr. Madhuri Patel ma'am, whose presence has added immense value to today's event. Their insights and wisdom have inspired us all and will continue to resonate with us for a long time. I would also like to thank the chairpersons of Fogsi PAC and Amogs PAC committees, Dr. Priyankur Roy, Dr. Monica Umbardan, for their exceptional leadership and support in organizing this event. Their hard work and dedication have been instrumental in making this event a huge success. I would also like to thank today's illustrious faculty, experts, chairpersons for their expertise, knowledge, and this has been invaluable for us. Heartfelt thanks to all the West Zone societies for their valuable contributions toward the success of today's event. Special thanks to all the coordinators and conveners for all the hard work to make this event successful. Finally, I would like to extend my gratitude to Team Corona, the makers of Code 3, Dydro Hope and See Hope, for their generous support and for believing in our vision. Without their support, this event wouldn't have been possible. Once again, thank you all so much for your valuable contributions today, for making this event a grand success. We hope to continue this partnership and make more such successful events in future. Thank you. Thank you very much.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Dr. Brennan, ma'am, sir.
Thank you, Vidhi.
Thank you.
Thank you, Vaidi, ma'am.
Happy birthday, Vidhi. Long live.
Thank you. Thank you so
On
much.
behalf of Corona Remedies, I also would like to thank you everyone, all the respected faculty members, and we like to arrange such more webinars in upcoming future, ma'am. Thank you. Thank you very much.
Thank you, Corona team.